All right, hello, good morning. Well, what a great day to be here. It's damp and dreary outside. It's good to be inside. All right, if it was sunny and shiny, then we would all feel like then we want to be outside. But welcome to our inaugural Critical Care Symposium. This is a great day for us. This is the first over for Houston Methodist. Before we go forward, I just want to give you a walk through a little bit of history of Houston Methodist Hospital. This is our second century of Houston Methodist. If you can see in the picture on the left-hand side, this is how Methodist Hospital started in 1919. And look at where we are in 2019. Wow. It's a whole first century was a remarkable achievement in so many fields, so many things. And the second century is really what is defined a lot more as unparalleled achievement and imagination and success. So this is here we started in about 100 years. To give you a little bit of perspective, we are 8 hospital systems, 7 acute care and 1 long-term acute care, about 900 plus thousand patient encounter, 800,000 plus outpatient visits, 100,000 plus admissions, 22,000 people work in Methodist system. Wow. I did not know until I saw this number. That's a lot of people working, and it makes this organization great. 4,000 plus physicians and 600 and now up to 700 faculty. 161 million for research and education. You know, remember when we separated from Baylor, we really had no residency program, no research funding, and we have done a tremendous at that. 1,900 credentialed researchers. That's an achievement over the last 10 years. And about almost 30,000 trainees. You know, that's a huge feat to achieve that in this time period. And I think that speaks a testament to all of you which are sitting there. We've got a research institute, education institute, multiple residency, and we've got affiliations with all across in the medical center and outside. So this gives you the depth and breadth of Houston Methodist Hospital system where quite a few of them work and everything. This is our different hospital, you know, the main campus. When I came to Houston Methodist 22 years ago, we really had this one main campus, and then it started to add much more with Baytown they acquired and Sugarland, and so the journey continues. And as you can see, we have 7 acute care, especially with Woodlands, and Woodlands took off big time in expanding. So not only that, we have a huge footprint in Houston and not in the state of Texas, we have accolades all across. We are the #1 hospital for U.S. News and World Report in the state of Texas. We are number 25 ranked hospital in the whole country in News and World Report. We got magnet status, we got a different institution, multiple vision. We got the Vision Quality Award again, and that's really comparing 102 top academic medical centers in the country. So it's good to be really in the top in some of the most prestigious institutions. So I just want to kind of share you all that this is where you all work and this is you are. So our focus really is quality of care. We've been ranked in U.S. News and World Report for 26 years. And of all the 4,500 hospitals, only 158 get ranked. And only 11 got ranked in Texas, and we are #1 hospital in Texas, and we've been ranked for 26 years. This is, you know, as you can see, the most nationally ranked, especially in Texas for 12 years, and consistently best hospital because of people like you who made a difference in patients. With all of these accolades, one thing I really very strongly believe, that patients are the center of everything that we do. And an academic medical center like us compete on safety and quality and service. Patients win because everything is about patient. Why we come here, why we work here is about patient. And when we collaborate with our partners, patients win. So it's not only what we do best, but how do we share and collaboration partnership. This is a lot of planning committee. As you can see, multiple workshops, 9 hands-on workshops, and I really like to thank every single one of them. They took their own personal time, family time, and one of them was dropped. Dr. Dalla was dropping me at home at around 9:30 last night because my Uber didn't show up. So it just goes to show how committed they are. So I'd like to thank Dr. Dalla and her husband to drop me that. These are exciting workshops, will be fabulous. You'll have a great time. And these are the sponsors which really supported for us to write up all the costs, especially for the Houston Methodist physician, nurses, RT, PT, staff, and everything to have that. And I'd like to thank all of them with all this. So I'm going to call Chris Rawls to kind of go over how this question answer will go through. Another thing is this event is being live streamed and is going to YouTube and everything in so many places around the country and around the worldwide. So this is another first for our critical care symposium that we are live streaming it. So Chris, you want to do that before I go introduce Dr. Vasily? Go ahead.
Yes, sir. Jesse, can you throw up the ARS, please? So in addition to the microphones that we have on either side of the room to ask questions for the speaker, we have the ability to text in your questions. And you can do this anytime throughout the day, and your questions will be recorded and moderated by one of the panelists or speakers here. So please feel free to text in your questions. It's pretty easy. The first thing you're going to do is text in Methodist to 37607 one time, and that'll allow you to join our session, and then from there on out, you can just text in your questions at will. Now, these instructions are also in your handout, I believe on the 4th or 5th page, so please refer back to that if you have any concerns or questions about that.
Thank you, Chris. Another first, very few symposium in Methodist hospital system have been sold out. We had to close our online registration 1 month ago because we were oversold. It's a good problem to deal with, but it was remarkable. So with that being said, let me introduce our keynote speaker, and anybody who works in critical care environment knows Dr. Vasily, but I like to read a little bit about him so that I can try to do some justice to He's a professor at Vanderbilt School of Medicine, has done tremendous work in so many areas of medicine, especially with focus on improving care and outcomes of patients with ICU-acquired brain disease, delirium, dementia. He's a co-director of the Center for Critical Illness, Brain Dysfunction, and Survivorship, which has amassed thousands of patients into cohort studies and an randomized trial, answering vital questions about ICU-acquired brain disease and other components of ICU survivorship. His team developed a primary tool, CAM-ICU, translated into 30 languages, which is used to measure delirium in an ICU-based trial and clinically at the bedside in ICU worldwide. Dr. Ely has been continuously federally funded for over 15 years. He has over 400 peer-reviewed publications and over 50 published books, chapters, and editorial. His wife is a pathologist, and together they have 3 daughters who are the light of their life. Welcome, Dr. Smith.
Well, good morning. It's Saturday morning, and everybody's here ready to go, right? My name is Wes Ely. It's a real privilege to be here, and Janice, thank you for inviting me, you and Faisal both. Chris Perme, my good friend, is here, and also Josh and Dustin, who are PharmDs and pediatric critical care. You have an amazing group of people at this medical center, and as I walked around in the hospital this morning, it was just such a large city that I was getting lost. I had needed a map, and I went to see my cousin. I found out last night at dinner when I was with my aunt and uncle that my cousin was in your hospital. And I need water, maybe. Sorry. Just a cup of water would be great. And so she's in your hospital with pneumonia, and I went up and spent an hour with her this morning, and I was reminded of just what a great place this is to work and to take care of people. And I think Faisal's right. It's all about the patient, and you've been keeping that at the center of your story, which is why you're doing such an amazing job. And this story that I'm about to tell you is all about patients too. And what's fun about it is that I'm about to show you some new data. I've got 2 new studies to show you, one of which was published in the New England Journal of Medicine just a couple of months ago and featured on NPR, and another one which was published in Critical Care Medicine and featured on NPR. So pretty amazing new data, and I hope that it's helpful to you in your practice. This is Vanderbilt. It's a shade smaller than Methodist, but it's still a big place. And I just acknowledge that I have had honoraria from several different companies. They're listed, Pfizer and Orion, Massimo, for CME activities I've done. I don't have any stock in these companies. I don't care if you use their products, but I want to make sure that you get those disclosures. I'm going to make my comments evidence-based and restricted to the peer-reviewed literature. This is our group, our SIB Center. We have 90 people doing research that I'm about to show you, and these people are from all walks of life. I was thinking about all the different specialties that you have here, and for example, Angela right over here, she's a nurse and a photographer. All these different talents. Way to go. But these talents that we bring to bear every day, hopefully we're answering a calling to care for other people. And these people are trying to do the same thing and provide you new information. So here's a gentleman that was the last person ever enrolled into the Mind USA study, which I'm about to show you the results from. I was taking care of other patients in the hospital, and the nurses here on the left, on the right of the picture, called me and said, Dr. West, please come and see our last patient. This was 15 years in the making. 15 years ago, we decided, you know what? People use antipsychotics for delirium. We don't know if they work or not. They're the standard of care, usual care, and we're going to set up the right set of studies to figure that out. And this was the last guy ever to contribute his physical journey through illness to helping us understand that. This is a patient I had 2 months ago, Mr. John. John was a patient who came in with an NSTEMI. During the hospitalization, he got pretty bad sepsis, and his sepsis, we got him better from that. He was on, here's the trajectory of illness, and he was way down here on the lower trajectory of illness, getting better. We're going to say less illness is low. He was down here, and then he got profoundly delirious. I was stunned, actually. I mean, we had him all the way over the hump of the illness, and he got so delirious. He was cussing, talking bad to his wife. He wasn't making any sense. And I thought, what is going on with him? And I said to the fellow, he's going to go down. I'm really worried about this. But there's a lesson in it, which is why I'm showing you his story. One thing he told me before he was delirious was, Doctor, he's a proud soldier. He's a veteran. And this is, I'm at Vanderbilt and the VA, and he was at the VA hospital. And he said to me, Doctor, my father was present around D-Day for World War II and came in, and he was around the beaches, etc. And he was in this black infantry. And so I told him that later that month that I was going to France to present the data from Mind USA in Paris. And he said, would you do me a favor? Would you take a picture of my father and put it on that beach? And so I didn't know if I'd be able to do that, but I'm going to tell you the rest of his story towards the end, and we'll come back to it. Look at what Dostoevsky says about delirium. In his book, Crime and Punishment, which I read last summer, 31 times he brings up delirium. And he says, strange to say, he seemed immediately to have become perfectly calm. Not a trace of his recent delirium, nor of the panic fear that had haunted him of late. It was the first moment of a strange sudden calm. Now, for us in the room, we think, oh, did that person get healed and the brain is now normal? Or is the person in hypoactive delirium, right? Because we know that sometimes the quietness of the brain is actually a dangerous place to be. And things like mobility and stopping drugs and engaging with the person, these non-pharmacological things can actually help the brain to get back. And I always use my arm as a brain totem pole. So here's normal, delirious, and coma, and we want that brain to come up to normal from delirium. I don't know if this person in Dostoevsky's study is better or still hypoactive. But bear in mind, hypoactive delirium, going from hyper to hypoactive delirium is a worse thing. Way worse prognosis in hypoactive delirium, which is why you as clinicians need to be aware that when your person's hypoactively delirious, that this is a bad prognostic finding. I'll give you two numbers. For every additional day that somebody is delirious, they have a 10% increased risk of death. This is independent of severity of illness, age, other comorbidities. 10% every day. So 3 days of delirium, 30% increased risk of death, independent predictor. Another number, 35% for every day predictor of long-term cognitive impairment. And I'm going to show you some data from that. But if you do the math on that, 3 days of delirium, you're going to have cognitive impairment when you leave. So huge issue for us in caring for our patients. By the way, one night I was at dinner in Nashville, and my father was here as a patient. He was getting a cabbage. And the surgeon called me and said, your dad did fine in the operating room, but he's very confused. My dad had gone urgently into the hospital. Not enough time for the story, but I didn't have time to get down here before he got his cabbage. And he said, he's getting confused, and we have this tool in the hospital to measure delirium. And I said, yeah, got that. He said, we call it the CAM. I said, I'm glad you're using it. Anyway, this is the picture of Mr. John's father. this is what he wanted me to remember. And this is what I carry with me to remember the looking in the eyes of our patients and saying, this is why I'm here. And remembering that the story that we're all weaving, we're all connected in this. And so to connect back into the 1950s, Engel and Romano, two famous professors, were the ones who wrote about delirium in this very famous paper, Delirium, a Syndrome of Cerebral Insufficiency, from Harvard and Rochester. These two people did EEGs and were the first to describe the slow wave manifestations of brain dysfunction in patients who are critically ill with delirium. I'm going to show you just a few quotes, just not want to read the whole thing, but look at the bottom. They say, this is a serious and perhaps tragic omission. And that is the omission that the physician who is greatly concerned to protect the functional integrity of the heart, liver, and kidneys has not yet learned to have similar regard for the integrity of the brain. And I am so guilty of this. I think in the ICU when I'm there with my patients, I just finished 3 weeks in the unit, and I'm so focused on the clavicle to diaphragm, the ventilator, the shock, the respiratory failure, that I even tend to overlook the integrity of the brain, and Engel and Romano warn us. They also say that the problem of delirium is far from academic. It carries the serious and possibility of permanent, irreversible brain damage. They were saying this 40 or 50 years before we had the data that I'm about to share with you. It was 2001 when we came up with the CAM-ICU and the DSC, and after that we started having an absolute surge in the number of research projects about delirium in critical illness. And one of those research projects was our study called the Brain ICU study. We call it Brain 1 because there's about to be a Brain 2. This Brain 1 study we published in the New England Journal, and what we found was that if you enrolled nearly 1,000 patients in the ICU on the ventilator from med-surg ICUs, people who did not have pre-existing baseline cognitive dysfunction, what we found was that they had, on average, whether you were over 65 or younger than 65, you had cognitive function that was way below normal, in fact, hovering around traumatic brain injury or Alzheimer's disease. Wow, really? At 1 year later, you had cognitive function that looked like AD or TBI, and you were just a pneumonia patient? Why? So 1,000 media agencies, including Al Jazeera, picked this up, and we're talking about this all over the world. Why is the ICU such a dangerous place for our patients' brains? And in fact, if you even go down into the 30 and 40-year-olds, they still are down around AD, TBI. And then the New England Journal editor asked me this question, Wes, what if they're just sick younger people and they have all kinds of stuff? So look, this is the youngest, the middle, and the older. And this is a lot of comorbidity, a middle amount of comorbidity, pre-existing, and no pre-existing comorbidity. So go all the way over to this graph and notice that 30 and 40-year-old people with no pre-existing disease, got out of the ICU with cognitive dysfunction. And that's what really, from Brain 1, we started saying, what is going on? Like, why are these people's brains losing all these neurons and they can't find their car in a parking lot or remember names? They're having to retire early, and this is clearly a big problem. So we actually have a research project now called Brain 2, and at Christmas this year we found out from the NIH that we got this $17 million grant to get the brains out of their heads. So when they're dead. When they pass away, we're going to re-enroll all these people, and when they pass away, we will set up a brain bank of their brains and actually study to find out what type of dementia is this, what can we do to prevent it and protect these people, and we're going to try and get to the bottom of this. Now, in terms of things that we already know, delirium is the #1 predictor of this problem, and we published this in the New England Journal. So for the longer you're delirious, the worse your cognitive function is likely to be at 1 year later. And we've followed these patients out to 10 to 12 years now. And we're at a decade out, and about 2/3 of them stay demented and or get worse. So whatever happens in that, here's Alzheimer's disease over 20 years of accrual, or 10 years. This is zipped up into a month or two of illness, and they end up with this problem. So this is happening under our watch, all of us, and I think that one of the ways to improve on this is having to do with the drugs we're giving and mobilization and family involvement. And I'm going to show you some data in a second that are going to support that. So first, now we're going to do the Mind USA study, published in the New England Journal, and then I'm going to show you the data from the ABCDEF bundle, and then we'll be stopped. Okay? So two big messages to share with you now. The Mind USA, which is a randomized trial of antipsychotics, and then the ABCDEF bundle, which I'm just going to abbreviate A2F bundle data on 15,000 patients. And when you walk out of here, you'll be able to say, okay, I know what's going on with antipsychotics as far as we are in 2019, and I know about this bundle. Let's see what we need to do here. So this is Ned Kassem. Ned Kassem was a stogie-smoking Jesuit priest doctor at Harvard. True. And he came up with the first idea to use antipsychotics in the ICU for delirium. And here's his abstract. It was 1978. And for the past almost half of a century, we have been doing this in medicine without data. There are some recent data to say that maybe what we were doing was dangerous. Here in 2005, you can see two papers in JAMA and the New England Journal saying that there is a risk of death from antipsychotics. And that is right about when I had this idea to say, wow, if there's a risk of death, maybe we're harming these people. Let's get to the bottom of this. Let's see if this works. Now, if this works, it'll be a short audio of Paul Wishmeyer, who's an amazing person, an intensivist from Duke, and he's describing his own experience with delirium. So why should we care?
I think they realized I was delirious, and I remember them even talking about it, saying, we can fix this, and giving me Haldol. And I got the Haldol, and the first night I got it, about 15 minutes later, my room suddenly became very bright white, and I felt like I fell through 3 glass floors, and my body shattered on the ground of my now 3-level hospital room, and every piece of my body, which would look glass, had a tag on it. And I had to walk up and down the stairs of my now multi-level hospital room, it seemed all very real at the time, and put my body back together piece by piece over the next 6 hours.
Yeah, pretty stark description of delirium. And implicating maybe the Haldol didn't help him, or maybe it made it worse, I don't know. Okay, now this is working, right? Okay, good. This is going to help me. So a couple weeks ago, I was on my 30th anniversary trip with my wife. She's put up with me for that long, so there's a saintly mission there. And we were driving along on the bikes in Miami Beach. She said, Wes, there's a sign back there you ought to take a picture of. You'll use it in your talks. And she's right, elderly crossing. Why relevant? So yeah, I am getting elderly, actually. Reveal, I found out that I have a compression fracture in my back. I said to my doctor, we need to check my bone densitometry, and I've got osteoporosis. Like, okay. So I'm like, wow, 55, got osteoporosis. So my father had it early, my mom had it early, but I'm aging, and these create vulnerabilities for us. And why is it that we should have a place to care for the people that are aged under our care that is dangerous? The place we care for them should be less dangerous. And so what I'm about to tell you is a way to make things less dangerous. This is the paper from the New England Journal in October. It was the first ever phase 3 randomized controlled trial of these drugs. There are previous studies. We set up one here, which is a phase 2 study, which was a feasibility study looking at antipsychotics. Here's one called the HOPE ICU study, which I was involved in as well. But look at the data. 33 people per group, 70 per group. This was a POIM study. We give the drugs IV all the time. This one was IV, but only 2.5 milligrams. So, we give way higher doses than that. We need more data than just these small sample sizes. Now, here's a study for prophylaxis, prevention of, and it's very large, but only 2 milligrams Q8. So people criticized this and said, yeah, I can see that there was no improvement with the haloperidol, but I mean, that's such a low dose. Maybe if you'd given a higher dose, it would have made a difference. So our study is actually the first ever, as I said, double-blind, placebo-controlled, 16 centers, conducted over 6 years, and we basically enrolled anybody who was in respiratory failure or shock. So real sick ICU patients, Apache scores in the high 20s, and we gave them a lot of, enough drug like what you might give. So we gave them Haldol up to 20 a day and Ziprasidone up to 40 a day to make sure that they didn't all get that much. The average person got 10 a day of Haldol, and the average Ziprasidone was half that, half of 40, so 20 a day. But they got plenty if they needed it, and we wanted to see what would happen. Yada, yada, yada. We analyzed everybody who was enrolled. We didn't skip anybody. We used very robust statistical techniques to figure this out. What were we testing? We were testing two hypotheses. One hypothesis is called the dopamine hypothesis, and that's that an excess of dopamine is not good. The reverse, also a depletion of acetylcholine, is not good. So dropping one neurotransmitter of acetylcholine or increase in dopamine, both thought to be contributing to delirium. So this is the way we tested the dopamine hypothesis, which was Haldol, because that's what it does, is it mainly it blocks dopamine. But then the other hypothesis would be, well, what about all the other neurotransmitters? Maybe there's histamine involvement, 5-HT, serotonin, and alpha, and dopamine, and all of that. So we picked another antipsychotic that has, it's like a big pie chart of lots of neurotransmitters. And we tested both of those hypotheses, okay? Now, we screened 20,000 people to get down to our 570 patients. And that's the real world. I mean, it's hard to find these people, and there's lots of reasons. A lot of them meet exclusion criteria. Some of them never get delirious. And what we did was we enrolled them when they were on the vent or in shock, and we randomized them once they became delirious. So it was a delirium treatment study. A few highlights. 60 years old, very sick, Apaches of 30 and SOFAs of 11. Most of them were on the vent, a third in shock, mostly ARDS, CHF, COPD, cirrhosis. Okay, so that's who we're dealing with. And how many were surgical? Did I say a third surgical? All right. So as a background treatment, so we had placebo, Haldol, and Ziprasidone, but across the board, all of them got the bundle. And we hadn't added the F to the bundle yet, so all of them got the A to E bundle. Now the bundle has the F on it at the bottom. We'll get to that in a minute. But look at the compliance rates with this bundle. Super high compliance, meaning that we standardized everything we could because we only wanted to test one thing. Like when you were in second grade and they taught you a controlled experiment is when everything stays the same except one thing. We tried to keep it all the same except for the antipsychotic. That's the point of that. And what did we find? After 40 years of using these drugs, we found that whether you got Ziprasidone, Haldol, or placebo, you had basically the identical amount of delirium coma freedom, delirium days, and coma days. This, as my mother-in-law told me, who's 92, said, so basically it was like giving sugar water. It's like, surprisingly, Mom, yes. That's basically what, with regard to delirium and coma. So on the delirium totem pole, when you were delirious and you got these very potent antipsychotics, you had no more days up here out of delirium and coma on the drugs than you did if you were in placebo. Now let me unpack that a little bit. Here's a survival analysis. You can see basically that across the three groups, 35% death at 90 days. That's a lot. 1 out of 3 are dying, but it wasn't the same across the groups. I mean, it wasn't different across the groups. Whether you look at time on ventilator, ICU discharge, hospital, or ICU readmission, same. No delta for these major hospital outcomes. And if you just look at treatment by type of delirium, there's also no difference. This is the hypoactive delirium, that quiet person we were talking about. And just look at the distribution here, and there's really nothing going on. So this is placebo, Ziprasidone and Haldol. Statistically, there's no indication that this corrected hypoactive delirium faster. And the same is true for hyperactive delirium. Now, I got a call last night from Gordon Rubenfeld, and he said he was on the DSMB for this study. He said, Wes, I'm worried that people are going to think that they should never use an antipsychotic anymore. I said, no, I think that's not what I'm doing. I said, I used Haldol several times in the past few weeks. He said, well, where are you using it? So what I'm doing is, what I think this study showed was that the drugs don't reduce delirium, but they also didn't harm people. So we did not see increases in arrhythmias, Parkinsonianism, neuroleptic malignant syndrome, any of these things that we were worried about. These drugs can cause drug-induced Parkinsonianism where you get rigidity. We did not see that. So basically they were safe, but they weren't helping. Now, where am I using them? The last bullet is to show you an example of where I'm using them. If the nurse calls me and says, Wes, Mr. Smith is wigging out, he's going crazy, or he won't tolerate his BiPAP mask, what do I want to do at that situation? As a clinician, I want to give something to protect the patient from hurting himself or others. I want to calm him down to be safe, so treat anxiety. I want to allow the patient to maybe tolerate a BiPAP mask, so not feel so claustrophobic. And I think there are two main ways that I do that now. One is alpha-2 agonists. So if I want to drip in the ICU, I'll use dexmedetomidine. If I don't want to drip, I might use clonidine. If I don't want to use an alpha-2 agonist or don't want to drip, then I'll use an antipsychotic. These are drugs that control anxiety but don't cause respiratory suppression, and those are my goals as a clinician. So I showed here that my treatments here, short-term control of agitation, alcohol or drug withdrawal, and severe anxiety, CHF, COPD, asthma, who wants a BiPAP mask. So I think there's absolutely roles for these drugs, but don't give them thinking that you're treating delirium. Okay? All right, one more message, and I'll stop and take questions. Let's go to the ABCDEF bundle. Thomas Paine wrote, a long habit of not thinking a thing wrong gives it a superficial appearance of being right. And I think that's what was going on with the antipsychotics. We thought, this is right. It's not wrong. Maybe it's right. And so we started thinking this is the right way. We also started doing it, though, with something else very important that I'm about to share with you about the A to F bundle. We began to think it was right to immobilize our patients and keep them sedated. We did not think it was wrong, and then we came all the way around, like Thomas Paine said, and started thinking it was right. And I'm going to show you data now that really undo that. If you want to hear a story, go to NPR. You can actually just go to our website. Go to ICUdelirium.org. That's our website, ICUdelirium.org. And if you just Google ICU delirium, you'll find it. And by the way, you might misspell delirium, but I bought all the URLs for misspellings of delirium, and it's going to redirect you. So this was my patient. He came in with 5 organs down, and his wife, amazing person, Karen, was with him. And NPR came to Vanderbilt to understand what was going on. He was told he was a dead man, and she was told that her husband was a dead man. They're very much alive and happy now, doing very well. He had profound delirium, and he has long-term cognitive impairment, and he's bummed about it. This is what we have to deal with. And the way that we have come up with to deal with this is called the A2F bundle. There are actually 40 Lancet, JAMA, and New England Journal papers supporting this bundle, and 350 other papers supporting it too. So this is steeped in the medical literature. It sounds kind of cutesy to have the A2F bundle, like, oh, it's the alphabet. But it's actually built around the principle that Malcolm Gladwell set up with the tipping point. Anybody read The Tipping Point? Great book, right? And Gladwell says, for people to remember something or use it, it needs to be a sticky message. So we use the alphabet to make it sticky. How do we manage our patients? And at the bedside, the nurse will say, Mr. Smith today was 5 on his CPOT, so his pain is not controlled, and we need better pain control. He got an SAT, a spontaneous awakening trial, where we turned the drugs off, and he didn't tolerate it. He wigged out. We put the drugs back on at half the dose. Or he got the SAT and tolerated that, and now we're moving on to the SBT. We're going to see if he can breathe on his own. These are 2 New England Journal papers. We've been paying attention to the choice of drug here. We've avoided benzodiazepines in him. We're giving him analgo sedation with just fentanyl. Delirium was assessed with the CAM ICU, and he's positive, and we ran through the Dr. Dre. I'm going to show you that in a moment. And the Dr. Dre allowed us to realize that we had a problem with these 3 drugs that are all psychoactive, and we've stopped those drugs. Early mobility-wise, we got this amazing person named Chris Perme to come up here, and she's getting him out of the bed this morning. And the family has been at the bedside for the past 2 days, and they're engaging with him, et cetera. So that's how the nurse presents this. It takes about 15, 20 seconds. It's a lot of data. It's all evidence-based. And what have we done to figure it out? Well, first, a postcard. I was at the Rock and Roll Hall of Fame, and I'm a huge Beatles fan, and Stones, and Who, etc. And this PS right here by Yoko Ono, she writes to her son, Yoko Ono, and this is in the Rock and Roll Hall of Fame. PS, the mind is a muscle, it needs exercise to strengthen it. Whoa, Yoko, you got it. You got it. That's amazing. Took my iPhone out and took that picture. Blown away by how perfect that is. The mind is a muscle, and it can't exercise if we have snowed it down to RAS -4. Come on. It's got to be up and going with Sudoku and Scrabble. So this is the Dr. Dre. The nurse says they're delirious, and by the way, I wrote to him. I said, Doctor. I said, Dr. Dre, we want to use your name for this mnemonic that people all over the world are going to remember, that if the patient's delirious, we can think of disease remediation, drug removal, and environment, DDRE, and that's how we're going to fix people. He didn't write back, but I'm taking that as a positive. So we got the Dr. Dre. So you guys can use this, and it's so easy, and it's so sticky. Every time somebody's CAM positive, what's the Dr. Dre? And let's think through these things for our patients. And the joke is on me, because I'll get back to Mr. John in a minute, my patient. But look at E, mobilization, sleep, day-night, hearing aids, eyeglasses. All right, so we'll come back to that in a minute. In the 70s, we walked our patients. In the middle here, we didn't, and now we are. So this is past and present. We've come full circle to walking our patients. Here is a picture from Poland, and this lady is pushing her ventilator in a grocery cart. You don't have to have fancy equipment. I know you do here. There's all the money in the world in Texas, but you don't have to have the fancy equipment. So what else did Dostoevsky say? On family presence, until today, the patient had been in delirium, and no doubt the presence of his family had a favorable effect on his recovery. Can you believe that? Right there in Crime and Punishment. All those years ago, the answer to the A to F bundle was right there. And we need to pay attention. Human connection. And the reason I love this whole story is that what we have done in the past is the patient comes into bed, we think, oh, we're so good, and we put them down, suppress them, we say, oh, we will protect them during this illness. And then when we think it's okay, we will let them back up. Wrong answer. And we were paying attention to beeps and buzzers. No. Look at the person in the eyes. Touch them. Hold their hand. Mr. Smith, squeeze on the letter A, and I'll spell Casablanca. And if they can squeeze on 8 out of 10 A's, or don't squeeze on the non-A's, they're not delirious. There's a person in there. I can connect with them. I can show them love. I can maximize their dignity. This is about human dignity and about showing a person that they're worth just as much when they're sick as they are when they're healthy. And what we have sent is the message of the opposite. When you're sick, we will disregard your personhood. We will pay attention to what we think is important and disregard the fact that you think it's important to talk to your wife, something like that. So, Dostoevsky had it right. Now, there are 15 papers on this bundle already, just on the bundle. Not even the 400 patients that built the bundle. So this is very evidence-based now. This slide, I'm sure, is, I can make all these references available to you. If you email me, I will do whatever I can within our team to help you get to the bottom of this. But this is the last study I'm going to tell you about. 15,000 people studied all over the country. It was 68 adult ICUs, 10 pediatric, med, surg, cardiac, the ADF bundle, 15,000 people. Dustin Hipp is a pediatric pulmonary critical care fellow here. He's been involved in the bundle for the kids. Thank you, Dustin. Here are the hospitals all over the country that participated in this project. I'm going to summarize. I think I went too far, didn't I? Yes, that's a good point. You were all involved in this, and you can see your H down there. So y'all have been involved in the program called ICU Liberation, all right? And thank you for being a part of that. You've been a part of this movement since the beginning. Thank you for making me not forget to say that. Methodist was one of the earliest hospitals. You were an absolute early adopter of this whole thing, okay? But times shift and new people come and they need to know your history of that. So you've been a part of this since for 15 years almost. What did we learn? We learned that if you look at the hazard ratio of ICU discharge, you can see that the likelihood of ICU discharge gets higher and higher further to the right as you go up in bundle performance from 0 to 30, 0 to 50, 0 to 60. So the more you perform the bundle, the more likely your patient is to get out of the ICU. The same is true about hospital discharge. This is a huge deal. Now think about this. Something you did in the unit is affecting them getting out of the hospital. Earlier, when we did just the SBTs, for example, we affected unit stay, but then when the hospital, it all got watered down. Now when you put the whole bundle in place, it actually is such a big effect that it affects hospitalization. But that's not all. Now the hazard ratio is on death. Could this save lives? Well, in all the individual studies, like the ABC study, we had a 15% reduction, absolute reduction in death. People thought, oh, that wasn't true. We were in Europe when this was presented, the ABCs in 2007. It was just the ABC at that point, Awakening Breathing Controlled Trial. And the doctor said, there's no way that that mortality effect is real. That mortality effect has played out over all these years. And now you can see it in 15,000 people, of which you contributed. As you go up in performance, you go way down in death. Now, the magnitude of that, I don't know, but it's saving lives. And we can tell that very clearly here. What I mean by that is the effect size, this wasn't a randomized controlled trial, it was a large cohort study. So we don't measure effect size there. Also, reductions in coma, delirium, and physical restraints. Now, a priori, before this happened, I said one thing should get worse. The awareness of pain should get worse. Because if somebody is not delirious and they're awake, they can now tell me they are in pain. And that's what we saw, an increase in the reporting of pain. So that was my litmus test that something was true and true in here. Now, it doesn't mean I want people in pain, but I want to know that they're in pain so that I can treat them. And that's what the benefit of this is. We also, big drops in mechanical ventilation. And this was, to me, the icing on the cake. Less ICU readmission and less nursing home transfers. So that brings me to the end of time for questions. I do have to finish with a story. We have a bundle, by the way, that our nurses round with. The whole left column is the ABCDEFs. Pain is A, SAT, SBT, here, delirium, mobility, and family. It's all right there. The nurse then goes through other things. Figure out some way to present stuff on rounds quickly. So this patient, he ended up surviving. His delirium lasted for 2 days. The drugs we were giving him didn't make a difference. We know that now. I still don't know what he was on, but I don't care because it wasn't changing his delirium. He wasn't anxious, so he didn't need an antipsychotic. Mr. John, you see those glasses in my pocket there? Every day that I was with him, I'll close with this story. Every day I was with him, he kept telling me how much he loved reading biographies. He was reading the biographies of the presidents, and he was reading a biography of every single U.S. president. He was so proud to be an American. And he had one of Roosevelt there on his bed, and for 3 or 4 days in a row, he was telling me his love of reading, but the book was always closed. And I never thought, because I wasn't thoughtful enough, about him not having glasses. His glasses were broken. And so he finally was delirious, and I said, oh my gosh, do you want my glasses? And I took those glasses out of my pocket, and I finally, dunce cap that I am, gave him my glasses. The next day, I kid you not, I walked in and look at him. Those are my glasses. His book is open. Look at his notes in this book. Is that crazy? He's writing down everything. He's studying the presidents. And he's telling me, Doc, this. He's going through on his fingers, telling me all the things he learned that night. Completely cam negative, all the way up there. That's what it's about. Thank you. The next talk starts in several minutes. I think we have some time for questions if you guys want to ask anything. Anything at all. It's a free-for-all. Dr. Zimmerman.
I just noticed on your antipsychotic study, the age range is fairly young, I would say.
Yes.
There were no 80, 90-year-olds.
There were some, but it wasn't in the 25th to 75th percentile. Okay. Yes, it's true.
So do you find differences between the very old and the younger?
Okay, so the question is, let's expand Dr. Zimmerman's question. She wants to know if there's a difference in the utility of antipsychotics according to age. In the interest of time, I took out subgroup analyses, but we looked at, the answer is no. The answer is no difference. But we looked at age, sepsis, no sepsis, on-off vent, high-low severity of illness. We looked at all the different subgroups, and we could see no indication that there was any subgroup that was strikingly receiving a benefit versus not. It was one of the most neutral studies I've ever seen. Another question? Anything at all? Oh, here we go. How do you safely employ the ADF bundle in patients who are ECMO and requiring paralytics? So if somebody's on ECMO and requiring paralytics, at the time that they're absolutely requiring paralytics, we obviously do not do a spontaneous awakening trial where we stop their sedation. Please, no. Very bad. I call it being buried alive. It'd be like being paralyzed, buried alive, where no, don't even think about that. So what we do is we pay attention to getting the family at the bedside and get them ready to engage with the family. I also tell the family, even though they're paralyzed and sedated, talk to the loved one as if they can hear you. Because you don't know what is getting into that patient's brain and what benefit there might be. I'll tell you an example. We recently, in a patient who was in the ICU, profoundly tachycardic at 140 for many days, we could not get them to calm down even though they were in a coma. We brought a dog. The patient was a dog lover, and put that dog in the bed. And within minutes, that heart rate was down in the 70s. It was shocking to me. I was like, I totally love dogs, but this patient's heart rate would not budge. And so externals matter even when you're in a coma, paralyzed and sedated. And then as soon as this person comes out of the paralysis, you better believe that we are doing the full bundle of the drugs, the awakening trials, the delirium management, family, etc. Next question. How do you diagnose hypoactive delirium? So the crux of the matter of hypoactive delirium is that you are inattentive. Remember this one thing, inattention. So what you want to do is find out in about 10, 15 seconds, can this patient pay attention to a command? So use the rapid letter A, which is saying A out loud. The patient's looking at you with their eyes, and you want to know, can they pay attention? Squeeze my hand. Okay, now squeeze my hand only when I say the letter A. You got it? Let's practice. A. Okay, if I say a different letter, don't squeeze. And you want to spell, just remember Casablanca. Or you can remember abracadabra. Say those letters. And they should squeeze on the A's and not on the non-A's. I'll give you 3 examples real fast. C, A, S, A, B, R, A, N, C, A. Okay? So the patient got it for 5 seconds and then brain out. Inattention, that's delirium. 8 or more right is attention and fewer is inattention. But here's another one. A, B, R, A, C, abracadabra. Every letter squeezing. Here's the last one. S, A, V, E, A, H, A. No squeezing. So all squeezing or no squeezing, that's inattention. All right? That's the answer. How do you, okay, any other questions? Thank you for your time. Have a good day.
Okay. Good morning, everybody. My name is Dr. Deepa Gotor, and I'm one of the moderators for the rest of this morning session. And before I announce our next speakers, I just wanted to announce a couple things. Slides actually to all your presentations, to all our presentations, will be available in a PDF format for a limited time after the end of the conference. And so to access your slides, visit our website at events.houstonmethodist.org/critical care and select the presentations tab. And the password is 2019 or 2019. And those registrants who have not signed up for workshops yet, please sign up at the registration desk during the break. And some stations are at full capacity. Please check the status at the desk. And we'll have a break at 9:50, and you can also view the exhibits and the accepted abstracts that are displayed right outside. So without further ado, I'd like to introduce our next two speakers, and they will be talking on ECMO versus prone therapy in ARDS patients. First up is Dr. Iqbal Ratnani. He is a professor, he's an assistant professor of clinical anesthesiology. He is certified in clinical research from Harvard Medical School and is also working on his doctorate in professional leadership in medical education at University of Houston. He has authored a book on critical care pearls, basics for critical patient care and board review, and is the editor of educational critical care website icupearls.org. He has conducted various critical care courses nationally and internationally, including training of staff in remote areas of Africa. Recently, he published a review article, The Role and Impact of Extracorporeal Membrane Oxygenation in Critical Care, in the Methodist DeBakey Cardiovascular Journal. And he'll be talking to us in favor of ECMO in ARDS. And followed by Dr. Cullen Hebert. Dr. Hebert is board certified in internal medicine, pulmonary and critical care and neurocritical care medicine. And he's our lead intensivist for critical care services at Houston Methodist Sugar Land Hospital. In 1996, he was one of two physicians who started the first critical care service at Our Lady of the Lake Regional Medical Center in Baton Rouge, which is the largest medical center in Louisiana. He has been recognized for his work with organ donation as well as telemedicine. At Houston Methodist Sugar Land Hospital, Dr. Hebert and his team initiated the ABCDEF bundle for standardization of care in the ICU patients, as well as the manual prone therapy for ARDS. He will be talking in favor of the prone therapy.
Can you guys hear me? Okay, good. So we'll talk about the ECMO. Before, just for the novice people, I didn't realize that I have to give a little explanation. I will go 2-3 slides forward just to tell people what is ECMO basically. When you cannot ventilate people on the ventilator, then what you do, you put a cannula in a patient, you get the blood to the machine, and you clean it, and you send back to the patient. I'll just go 3 or 4 slides forward just to give an idea, and then we'll start talking about that. Let's see. Which one's the forward? Okay, I'll just go forward a little bit. On this slide, you can see that cannula is coming out, going into the machine, blood goes there, and then you clean it, send back to the patient. Now we'll start talking about this. So that's basically an ECMO. When you cannot ventilate patient, you put cannula on them, get the blood out, send to the machine, clean it, give back. But there's a lot of controversy around it. ECMO came in 1979 first time. It's not a new thing, but it didn't go well because in adult patients there were so many complications that it didn't work. And then we saw the revival again 15, 18 years later because we learned a lot of things from our mistake. So we'll go back. So let's see. So I will ask you we are fighting today between ECMO and prone. I'm pro-ECMO, okay? And I will tell you why I'm pro-ECMO. And I'm very sure I'm gonna win. So, okay. I'm going to ask 5 questions, and you guys give me numbers, yes or no, okay? Here's a patient who's prone. And here is a patient who's sitting and looking at you. If you are a patient, which one you will prefer, there or here, right? That's one. Okay, let's go to the second one. You are working at night. Your respiratory therapist is coming to you with 2 ABGs. This is the ABG 7.23, PCO2 of 17. base axis minus 19, bicarb is only 7, 2 in the morning. That's another ABG, 7.44, 39, 354 PO2, base axis 3, bicarb 23, saturation 100%. Which one you will take? Thank you. Here it is. Patient is completely prone in the bed, early mobilization, early embolization. Okay? 3 out of 3, right? Okay. Nurses have no clue what to do. Okay. And nurses exactly know what they are doing. And the fifth one, and this is a little serious one, is that what is basically, when we hear dialysis, when we call nephrologist, oh, patient is not doing well, put on dialysis, nobody gets scared. When we call for the ECMO, there's a huge, oh my God, ECMO is coming. ECMO is basically a dialysis. It's a lung dialysis. You put the cannula, blood comes out, goes into the machine, you clean it. It's like a CRRT for the lung, right? Will you take it? Yes, why not? Right? So those were my 5 points, and I think I got all 5. Here it is. Before we go to the studies I'm showing about the ECMO, this is one study which was the basis right now becoming of everybody's talking about prone positioning because of this prone position PROVESA trial. And it was a good trial. Mortality at 28 days, 75 versus 38. Huge difference in mortality. Agree. Mortality at 90 days, I'm setting stage for my ECMO. Mortality at 90 days, 94 versus 56. Great. Vent-free days at 28 days, 10 over 14. Vent-free days at 90 days, 43 over 57. Great. This was the prone positioning. And pretty good trial, 229, 237. You don't get so many ARDS patients, and it's very hard to get that. Now, here are some of the major ECMO trials. 2009 was a very remarkable year for the ECMO. This is the time around, if you remember, the H1N1 was coming. And at that time, people were having a hard time ventilating patients. Prone was not there. These 2 trials came out, seizure trial and Brogan trial in 2009 at that time. Brogan trial didn't make much impact or much noise or waves because it has 78 patients and showed 50% survival rate. At the same time in Lancet, there's a trial came, seizure trial, which is considered as a landmark trial in ECMO. Which was done in Europe, 180 patients, 6 months survival without severe disability. This is important. 6 months survival without severe disability, 63%. Lot of criticism happened on this trial. The people who wrote about it, they said that basically those patients who were so sick, they could not get transferred to the good centers, and they died at the periphery hospital. Only good patients make to the ECMO centers. That's why your number looks so great. Lot of criticism. But after that, there was another trial done in Australia and New Zealand because H1N1 hit Australia and New Zealand really pretty hard. And they did this trial which got published in JAMA, and they looked into a lot of things. They actually looked into the patient's PF ratio on arrival. Their pH was 7.2 only. So that criticism on seizure trial that those patients were not that sick enough. They went on ECMO, they survived. What a big deal, they would have survived anyway. But they look into so pH was only 7.2. PCO2 is almost 70. You can't ventilate that patient. PF ratio only 56. These are the sick patients. 78% patients got weaned off from ECMO, 71% discharged home. Excellent trial. And there is another trial which came out, and then forward, looking into H1N1 patients, other ARDS patient. Another trial came out, the PRESERVE trial, and it shows survival rate at ICU discharge, 64%, and survival rate, it looks into 6 months. They followed the patient for 6 months and found 60% survival. And this is the trial I will talk, and this is the trial which came from the ELSO registry, extracorporeal lung registry. They look into, and they were actually, what they were doing, they were actually developing RESP score. There are 2 scores you need to know when you do ECMO. For the VV ECMO, if you are doing a VV ECMO for the respiratory failure, there's a score called RESP score. They have a website, respscore.com. And there is another score which is called SAVE score. That's the survival in the VA ECMO. So they were developing the score for the looking into the ELSO registry, but from that development of the score, they actually found that, that this data is coming from there. 49% of these patients, they were sick patients. 49% of these patients were receiving neuromuscular blocker. 20% were on inhaled nitric oxide. And you had hard time even ventilating even then. And 10%, they tried even high-frequency oscillatory ventilation. Was not working, went on ECMO. 57% patient went home. These are, so if you compare with PROSEVA trial, which was for prone, look into this one. And one trial I'm not talking here, it's called EOLA trial, which published in May 2018 in New England. I think that trial was flawed because there were 125 patients in both arms. But what we were doing, after they randomized the patient, they switched 35% from the non-ECMO to the ECMO. And when you do such a large number of patients, switch to the other trial. But even that trial got published in New England, despite that flaw. The reason is that what you will do, you put prone patient, you did everything, patient is dying. Patient is in control. And then you don't care about what's going on in the trial. You say, heck with the trial. I'm putting my patient on ECMO. So there were 35 patients who went into the ECMO. Even then, there they did not show much difference into the survival, but less renal failure, less stroke on those patients. But I didn't put that because I think that trial was flawed. Now, talking about the same debate, if you really want to read about the debate of prone or ECMO versus non-ECMO, January of critical care medicine, yeah, I think it's January. There is a good debate from Dr. Bartlett. He is the kind of a person from Michigan who is on ECMO. And last, this is our experience. We published last year from 2012 to 2014 here right at DeBakey Center. We were not that good at 2012, but as we get good, look at that. Our VV ECMO survival, 40%. And VA ECMO, we got up to 60%. So if you know you have a good team, then you know that. So it's all teamwork. So the thing is that somebody said that God has created all the animals in prone position because they don't have access to ventilator. If you want to evolve and be a human on an ECMO, that's fine. But if you want to stay there in prone position, it's your choice. I'll leave it.
Good morning. And here's the second half of the Lamborghini versus Toyota lecture. So, I have to figure this one out. Turning for survival. We want to talk about proning. And what I would like to talk about, just a little bit about a brief history of where it began, also why it works, and then bringing it around to talk about proning versus ECMO. So, beginning in 1967 was the first description of adult respiratory distress syndrome, which was later named acute respiratory distress syndrome, described by Dr. Petty and Dr. Ashbaugh and Associates. And it was 7 years later that Dr. Charles Bryan wrote a comment in the as a devil's advocate recommending prone positioning. as the only means of expanding the dependent portions of the lung. And over the next 4 decades, we had a lot of interest and a lot of anecdotal evidence that we knew we improved the patient's ventilation, we knew we improved their oxygenation, but we really couldn't improve their survival benefit. In fact, they had meta-analysis data suggesting that there was better outcomes in severe ARDS patients, but we just weren't ready to improve it all the way. And this is the ProSiva trial that Dr. Ratnani mentioned earlier, prone positioning in severe ARDS. It was done in France, published in 2013 in JAMA. It was 26 ICUs in France and 1 in Spain. And as Dr. Ratnani stated earlier, their criteria for severe ARDS was an AF to FiO2 ratio of less than or equal to 150 on 60% oxygen at least and 5 of PEEP at least. And so here's the study. The primary outcome was the measurement of their 28-day mortality. Their secondary outcomes included the 90-day mortality as well as others. For time on this discussion, I included only those that were significantly improved of those secondary outcomes. So I'm presenting the percentage of outcomes. So our mortality at 28 days was halved. It was 32% in the supine position and 16% in the prone position, and the numbers needed to treat was around 6. So we treat 6 patients, 1 patient would survive. But all of the other data that they showed, significant improvement, was really impressive. The mortality improvement stayed at 90 days. Successful extubation at day 90 was higher in the prone position patients. Their length of stay in the ICU was less, and their ventilator-free days at day 28 was more, and their ventilator-free days at day 90 was also more. And if we look at the probability of survival curve, if you look all the way to the right, maybe that's it. There's the prone group, and that's the supine group. All the way at day 90, there was significant benefit in survivability in those prone patients. But let's take a look at earlier in the course of the therapy. If you bring these lines back over here, you'll see that even early on in the disease process, there was a distinction between survivability in the prone group versus the supine group. And that was with just proning. So this is sort of how it works a little bit. So there's 2 rows on this picture. The first row is the supine position, second row is the prone position, and this is basically, I included this one because it gives you a better view. The patients in the supine position, you have air coming in, you get the driving pressure, it moves the anterior chest wall, which is more compliant up, diaphragm goes down, lung expands. Prone position, again, driving pressure from the ventilator goes into the lungs, prone, posterior chest wall goes up, diaphragm goes down. Sort of boring, isn't it? So we look at a cone representation that this patient has. We'll see that because of the patient's, this is the lung representation, taking the long piece of lung out of the chest cavity and just putting it right on the table. And you'll see that there is decreased number of alveoli at the top of the lung. Oh, I'm sorry. Here, and more alveoli at the base of the lung on the dorsal side. And these alveoli are compressed because of the weight of gravity, weight of the chest wall, weight of the heart, as well as the diaphragm and intra-abdominal pressures. So this pressure is less pleural, less negative pleural pressure, more negative pleural pressure here. So if you flip the lung around, patient in the prone position, you'll see that these alveoli are still there. The numbers of alveoli that are going to be ventilated are increased in the prone position dorsally, decreased number of alveoli, which continue to remain atelectatic here. So you take this lung and you put it into the chest wall. It's called the shape modeling diagram. And you'll see that these lungs at the anterior portion, they will hyperexpand, causing more strain on the alveoli, and these will be more atelectatic, not only from the dorsal compression, dorsal chest wall compression, but also the intra-abdominal pressures. And so if you take the patient and prone them, you'll see that these alveoli become more open and they are less distended. And that's partly because of the fact of the dorsal chest wall compression forces coming in. And the alveoli at the base of the lung, or the ventral portion of the lung, they remain more open. And so if you look at this last column with the proning, with the pulmonary aeration depiction, you'll see that, there it is. You'll see that on this part of the curve, the patient becomes, the alveoli become hyperexpanded. This patient, and these represent the alveoli that are more atelectatic. You turn the patient over on the prone position, the black arrows will prove that the patients become, the alveoli are less hyperexpanded, and you have more recruitment here. So the line of the gas to tissue ratio is a lot more favorable. So you have more homogeneous distribution of the strain on these lungs in the prone position. So this is basically why this works so well as far as ventilation is concerned. If we look at perfusion, and the patient's perfusion is in the lungs is directed dorsally, okay? So here you have the supine position here, and here's the dorsal portion, and you'll see that blood flow is directed dorsally to the dorsal position, blood flow here. Here, the patient is prone. Again, the blood flow is directed dorsally, and what do you see? What you will see is that there is less amount of shunted blood in the prone position here, okay? So that makes it better perfusion, and you have better ventilation, and so the A to FiO2 ratio should increase. And in fact, the shunt goes down approximately 30% here, okay? And if you add PEEP, high levels of PEEP for ARDS trials, you'll see that these lung units are stabilized. I'm sorry. These alveoli are stabilized, and you get less barotrauma. It also helps to decrease the amount of atellect trauma and biotrauma in those smaller airway and alveoli. So you have that as the physiology of why it works. And then this was a study, a lung-safe study that was published in 2016 in JAMA, and this was a snippet of studies that were looking at how good are we at treating ARDS patients. And it was done in a little less than 500 ICUs across 50 countries in 5 different continents. And what they looked at was the incidence of ARDS as well as the outcomes of ARDS. They wanted to assess the clinical recognition of patients of their ARDS. They wanted to look at the ventilation management as well as adjunctive therapy, and prone ventilation was one of their adjunctive therapies. So they didn't do very well. And again, this is the study was done in 2014, 4 consecutive weeks in the winter of 2014. So only about 16% of the time that patients died from severe ARDS were they giving a prone positioning trial. And what they also found that ARDS was under-recognized and under-treated, even at that time, and it was associated with a high mortality. So we come down to this one. This is a paper published by Dr. Lee, and this was in 2018, on an unproven and expensive therapy before proven and cheap therapy. And this is ECMO versus prone positioning in acute respiratory distress syndrome. So if we look, these authors looked at 810 reports that described ECMO in ARDS, and basically they culled it down to 26 reports where the authors had to respond to a consensus question. It was a very clear statement that these authors had to answer. Number one, how many of the patients with severe ARDS were cannulated for VV ECMO? And number two, of those patients, how many were given a trial of prone positioning before ECMO? 672 patients with severe ARDS were cannulated with VV ECMO. Only 31% received prone positioning prior to ECMO support. This is in face of the trial of the PROCEPA trial. Also, what was interesting was that the proportion of all VV ECMO patients that prone positioning was used before ECMO actually decreased after the PROCEPA trial in 2013. So here we have the Ferrari, right? Sexy treatment, right? It's something that we're going to give our patients right off the back. Got the Toyota, it's just solid treatment, solid therapy. And what do we come out with? The cost of prone positioning is significantly less. The complexity is significantly less. The complications significantly less. And the mortality is significantly less. I think this is a proven case of less is more. Thank you very much.
So can I have a show of hands who like Dr. Ratnani's ECMO version? We want to know if people are in a patient with ARDS, how many of you want to be on ECMO? Nobody? How many want to be on prone position?
Oh my God.
How many of you don't want to be on ARDS at all?
Any question?
Okay, so the questions are posted.
Want to arm wrestling?
Arm wrestling.
So what? I do have a question. So how, depending on the institution, putting the jokes aside, if the patient shows up in ARDS, what should we do? Really, that's a key question. Is should we try proning first and then ECMO, or should we just go ahead and go for an ECMO? So that's really the real life question. What should we do first?
I think most of the institutions are not equipped yet with ECMO, so there is a new strategies coming now, prone plus ECMO hybrid. This is a new thing coming. So as soon as you know that patient is in ARDS, ventilator is not working, get nurses trained to start proning very quickly. Because there is one criticism on proning is that you have a lot of 1/3 of your posterior lungs are open, so utilize that for first 24, 48 hours, prone them, get their hypoxemia resolved, because those, your lobes of the lungs are going to flood very quickly in 48, 72 hours, because when you prone the patient, all this inflammatory fluid is going into your good lungs. So you will have a good window of 48, 72 hours in proning. So by the time you arrange for the ECMO or transfer somewhere for ECMO, get your nurses quickly, do the prone. So this is a new approach coming, prone plus ECMO. As soon as you know ventilator is not working, prone them, start working on the ECMO. And if prone starts working, then you're good.
My question didn't go through. Sorry. Hello, my question didn't go through, and it is, at what point do you, or what measure do you look at, okay, now we need to start thinking of proning or start thinking of ECMO? Is there, I know it's not just one number, but what are you looking at, more of the PEEP? What kind of guides you into start thinking of that
Very
conversation?
good question. So basically you want to know, when do we start proning, correct?
I'm sorry.
When do we start proning? Very good question. Everybody with a low A to FiO2 is not in ARDS. Please remember that, okay? first thing you have to do is fit the clinical picture, okay? Is it sudden onset, right? Is it within 1 week of duration that their respiratory failure happened, okay? They're ventilated now, right? Is the chest x-ray, does the chest x-ray show diffuse infiltrates bilaterally? And lastly, is the ADFIO2 ratio equal to or greater than 60% oxygen and PEEP of 5 or more. So when we're making rounds in our ICU, we always get asked the question by some of the staff, should we prone? And let's time out, okay? Take a step back and find out more of the clinical course. Does the patient come in with Wegener's granulomatosis, that's diffuse infiltration that's been going on for several months, or do they have acute ARDS from pneumonia or sepsis pancreatitis? Okay, so I think you have to put those two all together before you make the decision to prone. And getting them prone as quickly as possible is the most important part.
One last question.
Oh, I have a question over here. So, and it actually kind of aligns with that question up there. So, one of the big challenges in prone positioning patients is the safety of turning them. And many times by the time we get to the point of proning, they're already, on pressors and inotropes, and they're already on high ventilator settings, obviously. So what recommendations do you have, or do you subscribe to any of the equipment that's available to help assist the staff in safely turning the patients without dislodging lines and tubes and drains and so on?
It's a very good question. I like that. Proning patients that are morbidly obese is very difficult. And what we try to do is, if we consider to prone those patients, I do ask the nurses to start measuring their intra-abdominal pressures, because you can worsen intra-abdominal hypertension, cause more rapid onset of renal failure, other organ failure. So typically, in those patients that we are very wary about proning, I pick up the phone and call Dr. Ratanani.
Actually, this is being an ICU intensivist at night. The worst thing is to get called for the ECMO evaluation. Very hard. I and Deepa went 3 weeks ago with the same situation. But we do a lot of good things in this hospital. And Dr. Masood knows that 10 days ago we had a patient, and I think this is a case report. I would love to write it. We actually saved a patient, 29-year-old with thyroid stone, who collapsed, and we saved with VE ECMO. Patient literally collapsed, and we saved it. So ECMO, if it's there, make a team. It's a really, really saving tool. But proning, not all hospitals have it.
Okay. So I also wanted to announce that we do have workshops. So if you have further questions on proning and ECMO, we have prone workshop demonstrating the whole scenario, like an ICU setting, and an ECMO workshop as well. So please do visit that. So moving on to our next presenter. Our next presenter is our session chair and needs no introduction, Dr. Faisal Masood. He is the medical director of critical care at Houston Methodist Hospital, vice chair for quality and patient safety, associate quality officer and medical director of the cardiovascular intensive care unit at Houston Methodist DeBakey Heart and Vascular Center. He also serves as professor of clinical anesthesiology at Weill Cornell and professor of anesthesiology at Houston Methodist Institute of Academic Medicine. Dr. Masood has been the recipient of the Golden Apple Award for Excellence in Teaching 4 times since 1999. He received the Dean H. Morrow Resident Mentor Award in 2001 and the most prestigious Fulbright and Jaworski Faculty Excellence Award in Educational Leadership in 2004. In that same year, he was elected a member of the Academy of Distinguished Educators at Baylor College of Medicine. In 2010, he received the Association of Professionals in Infection Control National Award for Heroes in Infection Prevention. In 2014, he received the John W. Overstreet MD Award, given each year to a physician at Houston Methodist Hospital who exemplifies the best of the medical profession. He has many research projects, publications, and is an invited faculty at local, state, national meetings, and international conferences. And today he will be talking to us on vasoplegic shock, causes and treatment. Dr.
Thank you, Deepa. So the challenge is that Dr. Wes Ely's lecture was fabulous. Dr. Hebert and Dr. Ratnani's challenging duel was fabulous. And now I'm between you and the break in food. So I have a very tough competition, so we do that. And as a reminder, as Dr. Couture mentioned, Dr. Wes Ely's, if you look at some of the paper that came out, our own CRISPR-Me was part of the paper. Our MICU was part of enrollment. So there is actually a mobility workshop. So you're more than welcome to attend that. And then there is a prone workshop also, which Dr. Couture is going to run. You can attend that. And there's an ECMO workshop also. So we're equal opportunity. We didn't take it from anybody else. So I'm going to briefly talk about vasoplegic shock. And the reason I chose this topic was because I felt that we talk about so many shocks. We were raised on cardiogenic shock. We were raised on hemorrhagic shock. We were raised on septic shock and other shock. And, there are certain underlying theme behind some of these shocks. And lo and behold, it seems to be is vasoplegic shock is the big picture and everything else is into feeding it. So that's one of the reasons I chose to talk about this shock. So these are the disclosure. I worked on advising and consultant on some of these things. So we're going to have objectives really is talk about the vasoplegic incidence. How much is it? What is it? And if I've done this poll with different people in different audience, and when I asked them what is the most common shock, and interestingly, people listed septic shock, some listed cardiogenic shock, heart failure, and I wanted to understand is vasoplegic shock plays into this thing. Describe the pathophysiology, why does it happen, and really at the end of the day, it's really about treatment options. So we'll recap some of those points. So our blood pressure is controlled with most of is really by the three: sympathetic nervous system, renin-angiotensin system, and argin vasopressor system, affecting your vasomotor tone, affecting your contractility, impacting your sympathetic, impacting your fluid retention, diuresis, and everything. So there is an interplay of these three receptor models which really impact most of how our blood pressure will react and behave. Any dysregulation, any outside entity, whether it's infection, whether it's other thing, can change those dynamics and that lead to hypotension. What has also happened over a period of time is that we are learning that hypotension over a period of time has such a negative impact. If you look at the septic shock trials and study, they were focusing on a map of 65 to 70. If you look at the kidney saving, it's about 75, 75 also. And in fact, new technologies are coming in which are doing a concept of predictive hypotension, that they are predicting that in the next 3 to 5 minutes, hypotension will take place, and the study they've done is in the operating room actually. So you can see the technology, the hypotension. Why hypotension is relevant? Because hypotension, especially MAPs sustaining less than 60 or 55, have to be a known risk factor for so many negative outcomes for neurological impairment, kidney, heart, brain. And one of the key drivers for mortality, as you heard from delirium and or renal, is basically patients who are compromised. So that's why hypotension is a key factor, and these things play a role. So what is the basic thing? Basic concept is physiologically, if you have a cardiac output, vessel maintain a certain tone, and and if the tone is lost and vasomotor impacted, even with the given same cardiac output, your blood pressure is going to be low. So you can have a great heart pumping very nicely, but if you don't really have tone, so basically what you're doing is you basically make a tubes. Basically our blood vessels, our blood carrying vessels are tubes. You make the tube size 4 times or 5 times, then you really have, no matter what heart is pumping, you really have no blood flow pressure. So you have flow, but no good blood pressure. And that does impact because pressure does drive. So flows can only do so much for perfusion, but the pressure is what really makes sure that it goes to all the cells and everything. So this is the basic broader concept. So then I start, and I pose this question, is it or it is the most common time shock? And we'll go that, why do I make the statement? Interestingly, when I started to do some groundwork for this lecture, I said, okay, I put in, and I tried to say, okay, let me see what are the papers out there, what terminology. These are the three most interchangeable terminology which has been used for this thing. It is distributive shock, vasoplegic syndrome, vasoplegic shock. And people in different papers, different literatures, different methodology are interchanging these things. But they're really talking about one basic concept. The basic concept is that your blood vessels are massively dilated and they do not respond to treatment and therapy. That means your blood pressure is on the low side no matter what you do. So this is the whole thing. And this is common for vasodilatation, which is very common. So it's a vasodilatation or a state of blood vessels where they are not responsive to routine therapy. And that's what is feeding in all of these terminology. So if you Google or you do literature search or PubMed search, you'll see very interesting terminology of this coming into play. That's why I kind of said, if you Google look at one paper, they're using terminology distributive shock, one paper vasoplegic syndrome, one's a plegic shock. But they're really talking about same thing. So these are papers which look at it, hypovolemic shock, the incidence about 16% because of losses or anything. Cardiogenic shock, you're talking about almost 16. Obstructive because of PE, temporal tension. Vasodilatory shock and distributive shock. Again, if you look on this study itself, they're using these two terms by themselves independently. So even then, people, because they recognize, people talk, we're saying the same thing but different labels. And the incidence 66, and they're listed driver septic, but there are other things a lot to feed into it. So the most common shock, and I did that with some of the medical students, is tell me the most common shock, and actually nobody could tell me the vasoplegic shock was the most common shock. And that's why I think it's fair to us to talk about it. There are a lot of things which feed into it, but this is what is happening. It has impact on you, whether it is different obstructive shock or cardiogenic shock or hemorrhage shock that affects on your cardiac output, your filling pressures, and your vasometratone or SVR. So these are all the things which are playing, but I just wanted to show you why it is the most common shock. And again, distributed shock, if you see this, and I purposely chose different paper in there to kind of show you how different people are labeling. So neurogenic, pressure-supported norepinephrine, anaphylactic, endocrine shock, drug and toxin-induced shock, septic shock, or post-cardiac bypass shock. The underlying theme is again, blood vessels not responding to conventional therapy or medication that we do. Okay, so that if you look at all of this category and if you put in your bucket where all of this coming on, it is the most common kind of shock, and we need to start thinking about it because towards what is the most common thing happens when patients end up dying? We cannot maintain their blood pressure. Okay, we keep on cranking up drugs. We say, well, patient not responsive. No matter what I do, patient not responding. So when we say that? Because no matter what drugs are we using, the patient's blood pressure is not coming up. So and unfortunately, most of the time, the end pathway of most of shock is a vasoplegic. Now, acidosis may play a role, and all the things may play, but it is the end pathway. But before they get to the end pathway, there's a whole lot of things we can do to pick up and treat. This is the basic pathophysiology. It may seem complicated, but it goes show the different pathway, whether it's SIRS, endotoxemia, interleukin role, SIR2, neurofactor, endosine. So all of these are interlinked because there is no one pathway. Because remember, vasoplegic shock is happening because whether it is infection, whether it is surgery, whether it is SIRS. So there is different reason why blood vessels react in certain way. That is why, if you look at it, that is why you have different markers, different things, all of them feeding into this whole thing, vasoplegic, non-responsive. Because there's no one reason, there's multiple reasons why. So the purpose of me showing this slide really was, there are a lot of things feeding into a vasoplegic and unresponsive blood vessel. So that's why I want to kind of show you the slide with that. So mortality is high. How high? Nobody has really said that, vasoplegic shock is equal to this one mortality. And the reason is because, we really didn't pull all of the disease or shock state which feed into. So we can have some idea, but not a fully clear picture. And that's why it's not very clear because it's not we studies of one entity, but as a component of septic shock, cardiac, there is some data, and people have tried to quantify some data as to, okay, if I'm using a lot of drugs and a patient doesn't respond, can I quantify that? Can I look at the mortality, how it feeds into, no matter what the cause is, okay? So they still try to do some of those things. And this was a very interesting in 2013. They looked at a vasopressor refractory shock state, okay, when vasopressor rate does not result in adequate arterial blood pressure despite you have resuscitated the fluid, and you can done that. And there's retrospective study of patients who did an equivalent dose of more than 1 microgram per kilo per minute. So whether it's like, norepinephrine, vasopressin, epinephrine, when they equalize the dose, this is what they were on. If you look at it, which is only 17% patients survived when they were requiring such high doses of vasopressor. And again, they didn't quantify what was the reason they were doing it, what was that, whether it's septic shock or neurogenic or anything. These are the patients who were refractory to what they were doing. So only 17% survived. And most of them were non-survivors. Stress disorder associated with some increased survival. But the key thing is this is very limited data, but this is an indirect way of quantifying the impact of mortality. Now, clearly, mortality in post-cardiogenic vasoplegic shock is different if you sub-segment it. Septic shock is different if you sub-segment it. And, neurogenic, if you segment it different. However, if you're requiring very high doses of vasopressor, the mortality is very high. Why is that important? It is very important for us to have a constant, open, honest communication with our patients and their families. If we can't say everything was great every single time we meet them and we are not honest with them, then they feel that, hey, everything was fine at 10 in the morning, and why are you telling me the patient, my loved one is dying? So you have to, when you're increasing the amount of medication or drips that you're escalating, it's very fair to have this thing that we are doing everything for your loved one, but the patient's body is not responding. Okay? It should not be that we're withholding anything. Remember, the purpose of medicine is to help your body get to the natural state of health. That means your body has to respond. If the body does not respond, no matter what therapies you're doing, they are not working. And in the end pathways, the patient will not make it. So our goal from a healing perspective is do therapies, Why do we give antibiotics? To help fight off the infection, so the body can heal. Why do we give blood? Because so that the body blood pressure goes. Why? So we do intervention for the body to respond, but if the body doesn't respond, and again, this is an example that non-response to anything, so that can allow you to have a better conversation. So it is vasoplegic syndrome. Again, I chose it because that's the most common terminology used in cardiac surgery and cardiac world. Okay, it's a recognized and relatively common complication of cardiopulmonary bypass, appearing about 5 to 25% of patients. Okay, even in ECMO, one of the issues we have to worry about is vasoplegic syndrome, and we have to use vasopressors for doing that, whether it is a VV ECMO, veno-venous, or veno-arterial. It's a long list. It's meant purposely to be small, so you cannot actually read it right now. That will force you that when you download those PowerPoint slides, you can actually see them. But I thought this is very important for you to have it after, but I purposely include this and one more slide, mainly for you to read for your entertainment purposes later on. So, but it just goes to show the kind of surgery makes a role. It is a routine or a long pump time. If they're very cool, it takes a long time. Other factor, because really the concept of cardiopulmonary bypass is that you are taking human blood, which is used to being in the human circulation, into an artificial circulation, all right? An artificial setup, and the body reacts, cells react to that, and that's they become less responsive. So that's the very simplistic form, but that's as simple I explain to patients and the family. That's why the body reacts. I mean, humans were not meant to have their blood outside their body and come back. I mean, that's never meant to be for thousands of years. So, diagnosis of vasoplegic shock, vasodilatory shock, a distributed shock, it can be pure or it can be mixed shock stage. And the reason I'm showing you that because you can have a cardiogenic shock along with a vasoplegic shock. So I can give an example. Last week, I had a patient who was in cardiogenic shock, was transported to us on Impella, which is a device to support the one side of the heart function. The patient was so sick, the patient had a right impella and left impella. That's as you escalate, sir. And patient was on CRT, patient was on vasopressin, norepinephrine, epinephrine, and and quite a bit high doses. So that's a patient who has a cardiogenic shock component and a vasoplegic shock component. It's not uncommon for us to have patients who are on left ventricle assist devices or artificial heart support devices, not all complete, that they are being supported for a cardiogenic shock and be treating vasoplegic shock. Patients who have right-sided heart failure have a cardiogenic shock plus a vasoplegic shock component. So isolated are there, but there's a lot of pool of patients who have a mixed state of cardiogenic and vasoplegic shock. Why is that important? Because you'll say, okay, why are you running Delirium on the patient, and then you're running vasopressin, that you're driving the heart, but then you're trying to bump up the SVR. It seems illogical and contradictory, but it is actually neither illogical nor contradictory, because you're treating two separately and you're trying to find balance. That way you can have better perfusion and you can have better, that's why you have to have much more aggressive monitoring on those patients. So this give you, this is a mixed out state, okay? So initially, since identify the state of shock, the first thing is ask. We should ask. You should look at the history. I know this is very 1970s, but please talk to patients or their families. The lost art of physical examination, I really feel that we don't do a good job of actually examining patients. And examining patients gives you so many rules. And whether it's me or others, we don't examine patients. I can't tell you that how paramount is to examine patients. We, as Dr. Vasily also mentioned, we focus on numbers. I'm not disputing the technology and everything has made a huge impact on numbers. But if I have to share you one thing, please, you or your colleagues, whether it's nurses, RT, PT, student, fellows, physicians, examine the patient. And I can tell you that, I've seen a lot of his H&Ps, and, we have had patients who show up with the stage 4 pressure ulcer on day 3. How do you do that? Because on the first H&P, everything's normal. Everything's normal. So how can you have everything normal and then you have stage 4? It's mind-boggling. People, and if you look at it, you'll be amazed that people don't even take their, they don't pull their shirts down or don't even turn them to examine. So please, physical examination is paramount. And now, we send labs, we send x-rays, and ultrasound has a huge role. And interesting, coincidentally, we have an ultrasound workshop today. So again, if you look at the theme, we are collaborating our lectures with our workshops. So we want to kind of include that because I think that's very relevant and very important. So why does the ultrasound make a difference? Because if your heart is pumping nicely and you really have no blood pressure, the odds are, either hemorrhagic, bleeding, vasodilatory. You can look at a lot of those things. You can look at the filling of the heart. You can look how a heart is contracting. You can do IVC. So all of these things you can do to kind of have a very good idea what is happening to that. So again, right side, IVC. So this is something we want to really push a lot more is ultrasound utilization. The cost of ultrasound utilization has become very cheap. It has become very portable. And in fact, I was in a meeting and somebody showed me this handheld new machine. Not handheld, it's like a mic. And it was extremely high good quality. It connected with my iPhone and the resolution and everything was fabulous. So, I mean, this is just a small thing which you can do that. And yeah, I know the nurses use ultrasound for IV access and everything. So ultrasound is your friend, in different ways. So please think of utilizing that. So once you do that fluids, and I imagine you've already given fluids, and you still do need to do monitoring, whether you invasive or non-invasive, whether it is cardiac output with their devices, if they can do those by skin, by ultrasound, by invasive, and all the stuff wise. The thing which I can welcome is if you come to our CVICU, we have a very high intensity of utilizing PA catheter. We love our PA catheters. So we use much more. That is, again, in medical ICU environment, that's a lot less used, but it's depending on the kind of patient you're dealing with. So you have to kind of focus. It may seem something which seem crazy in one unit and normal in the other because you're tailoring it to the patient. It's not all solution on. So supportive therapies, treatment of the infections, coming up bypass, stopping steroids indicated, discontinuing. The goal really at the end of it is getting the map appropriate. Now the downside of getting the map appropriate is human body is going to, human body is designed to save the brain and the heart. So blood,
pressure, flow, everything is going to try to say the brain, the heart. So what does it sacrifice first? It sacrifices your kidneys, it sacrifices your gut, it sacrifices your skin. So you'll see a lot more higher incidence in patients who survive high vasopressor therapy, that their kidneys will fail, they will have problems with absorption, and they may develop some perfusion problem to the fingertips, something like gangrene or anything. So that is something we have to be mindful of. So treatment choice, again, coming back to the original, all these receptors pathway have a role, and these medications and everything can individually. The goal is that you use a combination of things. So initially we used to have sympathetic pathway drugs. We had arginine vasopressin drug. Now in 2018 we had renin-angiotensin pathway drug. How the interplay will play out, how we will see. Purposely made this a very complicated, very thin slide, but this is for really actually homework. Okay, when you download, please review it. It's very important. It really, and this is mainly for my residents, fellows, and nurses. I mean, this is a reminder how all the receptors play a role. Why do I put this in? Because we a lot of times forget our basics. Why certain drug is happening, why it is not. We have to, at a period, regular schedule, to remind ourselves our basic, why this receptor, why this drug is working, why it's not. If I ask people a lot of times why norepinephrine is working, why vasopressin is working, we have no clue. You know, most of the time outside the septic shock guideline, there is no actually official recommendation that you should start with vaso first or norepi first or anything. We just do it mainly because of our experience, our comfort zone. You know, those are the most common things. So I just wanted to bring this. It's purposely, it's then you're going to be, you can download that to look at receptors, because that does play a role. And also with our angiotensin receptor, new drug that we had, that can also be part of. So these are the survival substance guidelines. We talk about fluids, crystalloid, vasopressor therapy, vitamin C, which is again trial, angiotensin 2. And again, the goal considered, they talk about protocol. Now, a lot of my colleagues and the surgeons say, well, Faisal, why can't we have a hemodynamic treatment protocol? I said, it sounds very logical, you know, it seems sensible, why we've not done it. So actually, I quoted a lot of my colleagues across the country. Very rarely that I found a specific protocol for some things, you know. And then when I asked them why, and most of the common is because, Faisal, they tell me, Faisal, you know, we do this protocol outside of septic shock and everything. Most of the patients are so different that it hasn't really paid out. So we're still looking for an one size fits all. It doesn't work, but you still have to have some algorithm, some approach that if you're using A drug to a certain dose, you need to think of B drug or a C drug or a D drug. So that's one of the key things you have to know. These are the mechanisms of action, where there's phenylephrine, alpha-1, with no beta affinity, norepinephrine potent, alpha-1 and alpha-2, modest beta-1 activity. This is the dosing range. Again, vasopressin with the difference about dosing range, telepressin, methylene blue has been used. If you know that for vasoplegic shock, we ourselves are given that. The data is all sporadic. Nobody really knows works. And this angiotensin 2, which just came across, and there's only one trial. They hopefully will doing more trials to see if it makes a difference. So this is what got a lot of attention in the lay media with NPR and everything, this magic solution of vitamin C, thiamine, and steroid, which will be the cheapest thing. So that was, the initial trial was from one institution. It has such a promising results that a lot of people have, as you can see, these two trials, and they're hoping that this will be positive because such a big impact, especially in septic shock and everything. So I do want to mention that, because that results, as you can see, all be coming out. That is something, again, they were focusing is easy and cheap. But we'll have to see how this pans out. So take-home messages: vasoplegic shock, distributed shock, vasoplegic syndrome. It's actually the most common, but more quite a bit under-recognized and underappreciated entity, but I think it'll come to our language much more. It has a very high mortality impact. Yeah, I showed the data. If you are a high dose of vasopressor and everything, your chance of surviving are very less. Cost, we don't know. The only thing is we have indirect cost. We know that septic shock and everything costs about $2 billion worth of cost, so you can add other thing wise. So it is expensive, we don't know. Now we have medication which affect 3 pathways. The sympathetic pathway, the vasopressin pathway, the renin-angiotensin pathway. And again, we're still looking at to see how we can make it a better protocolized approach in hope to make it better. So with that, I'm going to finish with that. I'm open to any questions.
Alrighty. If there is no specification, then we can certainly do. Oh, okay. Okay. So you want to read it loud, Dr. Dalla? Mike.
You base it off the patient's CVP? One of the questions.
I think the amount really has been only, which has been studied properly, is in the septic shock patient population. Septic shock guideline is 30 ml per kilo for a baseline. And again, even that, they ask that invasive monitoring or indirect should be measured, whether it's CVP, whether it's indirect cardiac output, whether it's ultrasound. So even in that fluid, that has been measured. So if you have to give a lot of resuscitative monitoring in a shock state, I would strongly encourage you. There are a lot of non-invasive monitoring available in this day and age, and obviously CVP is available. You can, in certain very narrow selected patient population, there's a role for PA catheter also. But in this day and age, if you're giving a lot of fluid volume out and the patient is unresponsive to fluid boluses, then you should be looking at some non-invasive invasive monitoring. But just to recap, the only data which has been very consistent is 30 ml per kilo in septic shock patient. How do you contend with mixed shocks? How do you contend with mixed shock? I'm not content with anything, but okay. So, but how do you, I guess, diagnose and management, especially in light of new engine like angiotensin II? So a mixed shock state. So again, vasopressin, norepinephrine, phenylephrine, angiotensin II are alpha stimulating drug. Their purpose is to decrease, to really increase your systemic vascular resistance and to increase perfusion. Okay, those are all vasoconstrictive drugs. In a pure vasoplegic shock in which the heart function is great, if you decrease the resistance for the heart to pump out, you're not doing service to the patient. Okay, so you have to make sure the heart is ability to pump. Now the mixed state is the heart is compromised and they don't have any vasomotor tone. So you can't do one thing, one or the other. If you do drugs, dobutamine, melanone, IV and epinephrine, you can impact the heart function, but if you can get the heart to pump better, but if there is no vasomotor tone, your blood pressure still will be low. So in order to treat both the things, you have to support the heart function, whether you're choosing to use dobutamine or epinephrine or melanone or devices, and you still have to get the mean arterial pressure. That's why in those patients, you have to have a lot more aggressive monitoring, invasive monitoring. These patients are mixed, so you may more than time they need PA catheter, more of the time they need much more invasive. So these patients, you can't just measure just by an arterial line on coefficient just by a CVP alone. They are much more complex. What about non-invasive monitoring with PA catheter? So non-invasive monitoring has exponentially increased in the last 15 years. And there's I imagine the non-invasive monitoring, especially, there is a hemodynamic workshop also in our workshop. You'll get to see it's not only about blood pressure. It's about your stroke volume variability. It's about stroke volume, how it is. So all that, so you'll learn. I'm going to not take up anything from them. So the data, the first was when I was doing my fellowship at Duke, the data came out that PA catheter is bad and it's killing everybody, okay? And that statement, a lot of people still hone through. But there is a role of PA catheter in a very select patient population, especially in cardiac surgical patient population. The data show that does make an impact and difference. In patients you're trying to measure pulmonary vascular resistance, it does make a difference. In patients you're trying to establish for right heart or LVI, it does make a difference. Outside those things, which is a lot more bigger majority, outside those category, PA catheter has not been shown to be improvement in mortality. And in fact, it's shown to be detrimental for mortality because people who were using it were not making the best decision because they did not know how to interpret. So if you're making a decision on bad information, your decision by default will be wrong. Even with the best intention, you'll make wrong decisions. Any other questions on that? Well, thank you so much. I think, okay, this one. Nursing often feels that mortality and morbidity are not communicated to families clearly and it is timely matter. If only 17% of patients with high doses. So that's right. That's why, I think we do own it. Physicians own it. We all own it. And I do agree with this statement that we all want to be good guys. We all want family to love us. We all feel that if we give anybody
bad news or true news, they will start hating us or they will start indirectly blaming us. That's human nature. Nobody wants to be the bearer of bad news. We all say, oh, everything went great. And unfortunately, we as physicians, especially as surgeons, I think we are used to that everything's great. And the poor nurse is holding, not really. So it's a cultural shift. We have to work on it. I would love to do that, but I think what has happened is what is opening that multidisciplinary team rounds. And in most of our ICU, when we do multidisciplinary team rounds, families are also present. That helps. What we did in our ECMO patient population, we have an automatic ethics and palliative care council and regular family meeting. That also helps. So we have realistic expectation. So what I would tell you, it is challenging, it is hard, it is human nature. What we have to focus on is realistic expectation. I tell families, as best I can, nobody comes to hospital for their food, and nobody gets admitted to the ICU. And I actively go after my resident who write, patient is stable. Stable patient don't blog in ICU. And unless they look exactly like the resident, they're not allowed to write stable. Okay? All right, thank you so much. We'll go for a break.
So,
going around
yeah.
Go ahead.
So we'll break for now, and just before the break, I just wanted to let you all know that we received about 12 abstracts, and out of which 5 were accepted, and they're all displayed right outside the conference room, and the winner will be announced at the end of this morning session, so please take a look at the abstracts as well. And as well as please visit our vendor booths and our sponsors. Okay, we'll reconvene at 10:30. Okay, I think we're going to go ahead and get started with the rest of our morning session. I hope you had a chance to look at all the exhibits as well as visit all the abstracts that were submitted. And, the winner will be presented a little later on, but I hope you all had a good sense of which would be the winning abstract. Moving on, the next topic of our presentation is on neurocritical care for the non-neurointensivist. And I would like to introduce our next two speakers, Dr. Kevin Emanuel. Dr. Kevin Emanuel is the medical director of neurocritical care at Houston Methodist. He has extensive teaching and research experience. To name a few of his expertise, he has a book chapter in Merit Neurology on spontaneous intracranial hypotension and has published abstracts on refractory status epilepticus, central nervous system vasculitis secondary to systemic sclerosis, infection rates and mortality after spontaneous subarachnoid hemorrhage, plasmapheresis for management of heparin-induced thrombocytopenia in the setting of acute intracranial hemorrhage. Following suit is Dr. An Nguyen. Dr. An Nguyen is a neurocritical care intensivist at Houston Methodist. He has fellowship in epilepsy and neurocritical care. He has been a co-investigator in numerous trials, including the POINT, ESSET, and IDEF. His interest includes neurophysiological monitoring in the neuro-ICU and has numerous publications, including a recent publication in Current Neurology and Neuroscience Reports journal regarding neurovascular physiology. And Dr. Kevin and Dr. Nguyen will be presenting the topic of neurocritical care for the non-neurointensivists.
Thank you. Can everybody hear me clearly? Fantastic. So we've been charged to talk about what we do for the non-neurocritical care intensivists. And we're going to start right at the beginning by systematically going through neuroanatomy by localizing the lesion. I'm joking. We're not going to do that. I know it's a flashback to medical school for a lot of the physicians here. All right. So we have a couple of objectives. We want to describe how we approach and evaluate a comatose patient. We're also going to talk about some of the different management techniques or ways of thinking for managing intracranial hemorrhages. Dr. Nguyen is going to talk about managing ICP crisis and also describe a management process for status epilepticus. So these are very, very common type of things that happen not just in neuro-ICU, but in any critical facility. Patients are going to come altered. One of the pivotal things that skills that we have to have is, yes, we can do CT scans, but the neuroexamination is something that you cannot replace. The CT scans and all the other fancy imaging studies that we do really just augment the neuroexamination. And for any patient, patients are not static. This is always a dynamic process. So you need something that's dynamic, like a neuroexamination that can kind of tell you if the patient is deteriorating, if the patient is improving. All those things matter, rather than kind of getting a CT scan, unless we eventually get some type of technology where there's a permanent CT scan on a patient's head, but how expensive that will be. All right. So one of the first things whenever you're doing a neuroexam, and I'll kind of briefly go through this, is you want to avoid confounders. So if the patient is sedated on propofol and the examination is, they are comatose, well, turn off the sedation. Same thing with paralytic. Patient was just intubated and now you can't quite get an examination. You want to kind of avoid those things that can be confounders. Level of consciousness. Everybody does the, alert-oriented times 5 or however many. But really, level of consciousness. When you walk in the room, you want to kind of see what your patient is doing. If they're watching TV and they're alert and they say, hey, doctor, they're alert. If they are sleepy and you kind of talk to them and they open their eyes and yes, you're getting a little bit sleepy, you can still talk to them, that's more lethargy. Now, if they're in a stupor, you kind of have to give them stimulation, and that just to keep them awake, that's more of a stupor. If they're comatose, they're not going to respond because they're comatose. Brainstem reflexes. Everybody says that the eyes are the window to the soul. There is no neuroexamination that's complete without doing brainstem reflexes. And at the very least, look at their eyes. Get one of those really bright pen lights. I forgot to bring mine. so that you can actually see what the pupils are doing. If pupils are fixed, dilated, you may have a problem, in which case they'll contact the neurosurgery folks. Dr. Wynn, myself, we're always available, so that's one resource that you can always use. Motor testing, strength testing, and there are different levels to this. There's a patient who's following commands. For patients who are following commands, I don't necessarily need to go give them a trap squeeze or do a sternal rub. They follow commands. Localizers, what I mean by localization is if I give a patient a stimulus here and the patient tries to reach for that stimulus, that's localization. Withdrawal is just as it implies. The patient is moving away from that stimulus. Flexion. Now, flexion is the patient, this is going to be just like a reflex, essentially. They're going to kind of do this every time, regardless of where you give them stimulus. Extension is the next step. The patient is going to do this. All those give you an idea of what the patient looks like. And some patients, they may have no response. Sensory examination, it's really, there are different modalities, but we don't have enough time to go through that. Cerebellar testing, also very important. So, we use a lot of scales to try and communicate a lot of information, and one of them that we use is the GCS. GCS is from 3 to 15. It's not 0. It's not 20. They can't over excel on their GCS. And I'll leave this kind of as a reference so that everybody can kind of see what the GCS means. But it's a good way to kind of communicate what the patient's coma score looks like. Now, some terminology, minimally conscious state. These are patients that kind of have some partial awareness of what's going on. Vegetative state, there is no interaction with their environment. They may have an adequate sleep-wake cycle, but they don't interact. If this becomes more than 4 weeks, they go into a persistent vegetative state. Coma, this is a deeper level of lack of awareness, lack of sensorium. They're in a coma. And of course, brain death, no brainstem reflexes. All right, so this is just kind of giving you a picture. This will be the only thing I'll talk about with localization of what can cause comas, be it diffuse hemispheric damage, bilateral thalamic, or even brainstem effects. Now, let's talk about ICH. ICH involves, it's a really heterogeneous picture. It can include TBI. In this specific one, I'm going to talk about spontaneous. So these are patients who don't have trauma, patients who didn't have surgery. All right, so ICH is not a single event, it's dynamic. And the reason why I say it's dynamic is because when a patient initially comes in, we get a CT scan and we see a bleed. But the issue is we need to subsequently follow these patients because most of these patients are actually going to get worse, and they get worse pretty quickly within the first 12 hours. And I'll kind of show you a representation in a second of just how this can, in fact, affect the patient's mortality. Now, this is a picture, a CT scan, axial, non-contrasted. It shows you, this is the intracranial bleed. And this is at 2 hours of onset, and you can see what happens in just 4.5 hours. The patient changes, and this becomes really significant, as I'll mention. Now, how do we evaluate ICH? ABC. One of the things that has really shown that our patients do well when they have intracranial bleeds is that we're just better at doing basic critical care. Definitely history exam, imaging studies. Very first thing first, get a CT scan. Don't forget the neuroexamination. This is something that you're going to follow. Because if a patient was following commands and now they're extending, something different has happened. Because with the CT scan, like I mentioned, even if we get it within 4 hours, as you can see with this type of patient, a lot has changed. This is really more for your reference, just to kind of give you some of the modalities that we do to kind of give us a little bit more information. But the basis is really the neuroexamination followed by the CT scan, and of course, laboratory studies. Now, ICH score. What the ICH score does for us is that there are 5 independent factors that really talk about the 30-day mortality and actually some of the functional outcomes of patients about 1 year. And this kind of gives you a better idea. Well, let me go back for a second. It includes the GCS, the bleed, IVH, if this is infratentorial, and also the patient's age. Now, depending on the scoring, as you can see, there's a big difference between a patient who comes in with 0, 1, and somebody who has greater than 5. Now, a word on the ICH score. It is not that the patient walks in on the you see them in the ED or wherever that very first day and you say, well, you have a ICH score of 5. That means that your mortality rate is almost 100%, and then we make the patient DNR. Patients who typically are treated that way, it becomes a self-fulfilling prophecy that those patients, of course, will die. So I would hesitate to use this when talking to families right at the beginning. Save that for day number 3, day number 4, when the patient really declares themselves, because as you will see, there are certain interventions that we can do that some of these patients actually improve. All right, so this is just a sample to show you how we calculate the ICH score. What it comes down to is, for this particular patient, ICH score 13. Now, when that bleed expands, you can see the ICH score now changes just in a matter of 4.5 hours from a 1 to a 4. The mortality goes from about 13% to 97%. So something needs to be done for these patients, and it needs to be done pretty early and very quickly. You don't want this to happen. All right, so what do we do? Again, general ABCs. Now, a word on blood pressure. There have been several studies that have been done in the last couple of years, the INTERACT-2 and the ATTRACT-2 studies. And really, what it comes down to is that it's not unreasonable to have a blood pressure less than 160. For patients who come in with a blood pressure 150 to 200, it's not unreasonable to be a little bit more aggressive to put them about 140, but 160 is a very safe place to start, okay? Agents that we use. Typically, I like to put in an A-line in most of the ICHs that come, unless it's a really small bleed, and I like to use the drip. Nicodipine is my go-to, because one of the things I want to prevent is the patient's fluctuation in blood pressure. I don't want too many highs and too many lows, so that's why I use nicodipine. And then, of course, reversing anticoagulation, because a lot of our patients are going to be, especially on the new NOACs. Fluids, avoid fevers. Hypothermia does not help, but preventing fevers seems to be what our goal is. And then another word on seizure prophylaxis. A lot of times we start these patients of seizure medications. Not everybody needs to be on seizure medications, because these medications do have their side effects. For example, patient with ICH, phenytoin, thrombocytopenia. You don't want a patient to be thrombocytopenic while they have an intracranial bleed. Avoid different highs of glucose. And of course, monitoring these patients. These patients do better when they're in a specialized unit. People who take care of these patients regularly. And of course, surgical intervention. Now, for infratentorial bleeds, cerebellar bleeds, these are patients that we typically will want immediate surgical intervention, particularly if this is a larger bleed, just because the intracranial space in the posterior fossa is not big. So these patients don't have a lot of time. They may go from talking to you to fixed dilated pupils in a very short amount of time. I'm going to save this as a reference for you for reversal of anticoagulation. If the patient comes in Coumadin, Kcentra is my go-to. If Kcentra is not available, then of course use PCC. For the NOACs, if this patient comes in with digabatran, use indirusumab. If a patient is on one of the factor 10 inhibitors, Andexxa alpha is one of the things that we have. All right, subarachnoid hemorrhages, and I'm going to kind of be quick. Subarachnoid hemorrhages is one of the most interesting bleeds, in my opinion, because it's a bleed that has kind of 3 phases. There's the initial phase where there's the bleed from a ruptured aneurysm, but you got to fix that, because if these patients rebleed, almost 40% of them die. So it's a very, very serious thing, something that you need to do very, very quickly. Blood pressure management is one of the things that we use initially, but if these patients can be clipped or coiled to secure, do that as quickly as possible. Send them to a center that does this very often. The next fight that you're going to have is ICP, hydrocephalus kind of fight. And my colleague will talk more about ICP. And then the next fight will be the delayed cerebral ischemia. All right, so if a patient comes in, worst headache of their life, please CT scan for these patients. If there is nothing on the CT scan and you're still very suspicious, this is a different kind of headache. I've never felt this kind of headache before. It was sudden onset. Get an LP so that we can look and see if this patient actually does have subarachnoid. Now, different scalings that we use. The Huntington-Hess scale, we use this kind of as a way to describe the patient clinically. And I'll kind of let you guys, this is a very self-explanatory, but there's a big difference between the patient who comes in with a grade 1 and a grade 5. The Fisher grade score is actually looking at the CT scan, looking at the thickness of the blood, or if there is any intraventricular blood. And this also has been related to the incident of vasospasm. Now, how do we manage this? Like I said, you want to prevent these patients from rebleeding, so secure that aneurysm. Measure blood pressure. Like I said, I love drips because I want a steady state. I don't want any fluctuations. It's not unreasonable to keep the blood pressure about 140 before these patients are unsecured. Now, once they get secured, that kind of changes a little bit. For patients who you cannot secure, using something like Amokar, for example, tranexamic acid, is certainly reasonable, less than 72 hours. You don't want to continue this for days and days because it does increase the risk, particularly of MIs. Surgical clipping or endovascular management. And if those are not amenable, then the neurosurgeon will essentially continue to monitor this patient to see what can be done. Because there's some aneurysms that are just not amenable to coiling, and usually those cases we clip. Hydrocephalus, symptomatic hydrocephalus. This happens sometimes very, very quickly. And a lot of times this is because of the obstruction from the thick blood caused by the subarachnoid. So a lot of these patients will get an external ventricular drain, and it may end up that these patients end up with a shunt permanently, like a VP shunt. All right, so management. One of the things that we do that's a class 1 level A evidence is giving nimodipine to these patients. Typically, the dosing is about 60 milligrams every 4 hours. If the patients are not really tolerating it or they're becoming hypotensive, sometimes we may change that to 30 every 2. Now, it's not to prevent vasospasm, but we have seen in the evidence that patients do better on nimodipine. You don't want these patients, in the past I think we used to do triple H therapy, now we do more double H. Number one, you want the patient to be euvolemic. You don't want these patients dry, you don't want them volume overloaded. For patients who actually start showing signs of DCI, then using blood pressure, increasing their blood pressure to kind of see if this overcomes the vasoconstriction certainly helps. Different centers have different ways of monitoring for vasospasm, but one of the things that they can do is using transcranial Dopplers, and in some places they may actually do angios that kind of set dates, typically post-bleed day 7, 8. All right, I think it's my time.
Can everyone hear me well? So I'm tasked with the next 2 talks, and these are going to be pretty dense, so not all these slides I'll cover, but they're going to be there for your reference, okay? So the first part, intracranial pressure. So intracranial pressure, it's governed by the Monroe-Kelly doctrine. So it states that the brain parenchyma, along with CSF and blood, it's confined within our rigid skull. That means that the brain is, once it's compliant, or when it's still compliant, if you have a little bit of increase one of these 3 substances, you're still going to be okay. The problem is when you have too much blood or you have a tumor and the brain is no longer compliant, that's when you actually get in trouble, and hence intracranial pressure problems. In terms of clinical signs of high ICP, it's very nonspecific. Generally, a patient's going to be altered. They're not going to be able to talk, verbalize as much as before. Headaches are usually another common problem as well. In terms of cranial nerves, the first cranial nerve that's usually affected, not always, but usually affected, is going to be cranial nerve 6. So a lot of times patients have nystagmus. So if you ask them to look to the left, to the right, usually they can't get it there, okay? And that's because of cranial nerve 6 palsy. For measuring intracranial pressure, we have different ways of actually doing it. So the most common one that you see, this intraventricular here, so it goes into the ventricles, hence intraventricular. The other name of it is EVD, that's external ventricular drain. It has many advantages. As you can imagine, it goes into the ventricles, So not only does it measure ICP, but if you have issues in terms of pressure-wise, you can actually drain it. And we'll touch on that in a little bit. The other drains, or the other monitors, excuse me, you have the interparenchymal monitor. And I suspect within probably the next couple of years, we'll be using a little bit more of this just for multimodality monitoring. So this goes into the white matter of the brain. And if it goes here, yes, it gives you a measure, but you can't actually do anything. It's not therapeutic. It only gives you a number. You can't drain from it. There's other drains as well in terms of epidural drains, subarachnoid drains. So what are the indications then? So Dr. Emanuel last touched on subarachnoid hemorrhage. Well, of course, if someone has intraventricular bleeding and there's signs of hydrocephalus, of course they should have a drain. In most cases, again, the EVD. So what I'm showing these indications, this is from the Brain Trauma Foundation guidelines. So if you suspect someone that has trauma, if they have a GCS of 8 or less, and this is, if we have a lot of anesthesiologists in the room, this is also with the intubation component, but the GCS less than 8 and an abnormal CT, the evidence says you can consider placing an EVD. The other indication, however, is if you have a normal CT, and the story fits with TBI, if you have two of the following, so if age is greater than 40, systolic blood pressure less than 90, or if there's signs of posturing on exam. So what's interesting is this number, this age 40, before when we teach medical students and these things, we're always taught, oh, you know what, it's patients that are older. Now that I'm getting close to it, 40 doesn't seem so old though, does it? So I mentioned for most practical purposes, for ICP monitoring, it's gonna be our EVD that we use. So this is just a typical EVD that we have in the unit. So a couple things to point out. For an EVD, our nurses know this very well in the neuro ICU, but there's a lever there, so it always has to be aligned. It has to be aligned with the external auditory meatus, and the reason for that is when a patient is supine, that about estimates the level of foramen Monroe, so that's going to be our point of contact, if you will. The other key point to this is with an EVD, the only way that you're actually going to get a pressure is if it's clamped. So if it's open and running, whatever it shows on the screen, that's not accurate, and that's always important to understand. And so these are the other devices that I touched on briefly. And so this is an example of a bolt. More or less, it's an introducer, if you will. And again, our neuro ICU, taking it to the next level, in the next couple of years, what we want to do is more multimodality monitoring. Monitoring for brain tissue oxygenation, monitoring other components as well, brain temperature, et cetera. One of the things that's always gotten me is in terms of measuring units. This is something that's been gone in history and it will never change. But so if you were to do a lumbar puncture, the units are going to be in centimeters of water. If you actually ask a nurse, what is the EVD set at? It's also centimeters of water. But what's actually on the monitor, it's millimeters of mercury. So always keep that in mind as well. So we'll come back to these 2 points though. So in terms of ICP management, we first talk about medical management of this. So the things that you can do right away when you come in, you want to make sure that the patient's head of the bed is elevated. You want to promote drainage, venous drainage. You want to make sure that their head is centered, just in case a lot of us, we have one side, either the right or left, that's dominant in terms of our internal jugular. And if you can imagine, for instance, if my right side is my dominant side and my neck is twisted to that side, drainage isn't going to happen so much, and you can have worsened ICP. You can hyperventilate a patient as well. So in general, though, hyperventilation should only be done brief. And the idea is maybe PCO2 30 to 35 and do it for 25 to 30 minutes as just a temporizing measure. Then we have medications that we can give. We can give mannitol, we can give salt bombs. For most intensive purposes, if we're giving it for high ICPs, there's no difference. There's some patient considerations that we think about, but you know what? If the patient has a high ICP, they're gonna herniate. Whatever you have next to you, if the patient has a central line, fine, give the salt bomb. If not, mannitol is there, go ahead and give the mannitol. Of course, if a patient's intubated, you can increase the sedation, the analgesics as well, and of course, all this, if these fails, surgery needs to be the next step. So this is just an algorithm that we can follow, and I'll leave it for your reference, but these are the things we talk about. The last thing, the barbiturate coma, so this is really sedating someone, obviously, right? You're putting them in a forced coma. What I left off on this is cooling. So there's 2 trials that was done. One is called Eurotherm. The other that was recently published, the PRISM trial, It shows no advantage in these cases. If anything, they're probably worse outcomes. So we don't cool for pure ICP. So this is, again, for reference in terms of multimodality monitoring. So the last few minutes, I want to touch on status epilepticus. So people know what a seizure is, but in terms of defining status epilepticus, so it's seizures lasting 5 minutes or longer, or having 2 seizures where they don't come back to baseline. If there's a convulsive status epilepticus, you can imagine there's non-convulsive, where you can only detect it with an EEG. And actually, it's a non-convulsive that happens mostly in our ICU patients. This is a very simple slide, but yet very important. If we understand this, we understand seizures very well. So seizures is just hypersynchrony of neurons. So you imagine anything that increases action potentials. So the excitatory postsynaptic potential, sodium influx or calcium currents, will cause you to have seizures. On the other hand, if you can imagine things that hyperpolarize, right? So potassium efflux, chloride influx. So this is how benzodiazepines and barbiturates work. Low pH acidosis is also proven to actually help with seizures, and this is the basis for a ketogenic diet. The key point is when you see seizures, you need to treat it fast and aggressive. If you look on the first part of the slide here, so with the first seizure, these are GABA receptors. During the first seizure, you see many GABA receptors here. During the 10th, 9th, 10th seizure, though, there's a downregulation of these GABA receptors. So you keep these seizures going, though, your benzodiazepines are not going to work. And so that's the idea. So the workup is just like any other workup. You want to find things that you can correct quick. So ABCs, you want to make sure they're not hypoglycemic. Most cases, they're going to, if this is a first-time seizure, they're going to get some kind of brain imaging. And of course, a CAT scan is so quick and readily available, so they'll get that. If the patient needs an MRI, and also a lumbar puncture, I would recommend doing the MRI first. You can actually have some enhancements after doing a lumbar puncture because of low pressure in the brain that you might miss. So this is going to be, we're going to skip through this a bit. So in terms of different therapies, so first-line therapy is going to be benzodiazepines. The second line, so we have choices here. We have fosphenytoin, valproic, or Keppra. Right now, what's endorsed by the Neurocritical Care Society is either fosphenytoin or valproic acid. Keppra hasn't been studied well enough yet. So that's what we generally use here. So the idea is seizures, benzo control, start them on an agent, usually fosphenytoin or valproic acid. For patients that are refractory to this, of course, they need to be intubated, and this is when we talk about sedation with Versed or propofol. These are some of the pharmacologic agents that I discussed if you understand the slide before. And in terms of non-convulsive status, though, this is essentially, we treat it in our ICU, we treat it as aggressively as someone that has convulsive, because if they're not waking up, the idea is they're seizing, that's why they're not waking up. So I know that was a lot, but that was a whirlwind. So you can refer to some of these slides for it, though, but I made it right on time.
Questions?
So can I ask a question, not being a neurointensivist, what would be the top 2 messages you want to share with us, because we will, all the ICUs will have patients who are in neuroemergency situation, and I'm not a neurointensivist, and neither, unless you're working in neuro ICU, the nurses are. So if you have to give us 2 top things to focus on, please share with us.
Well,
go
ahead.
So I can help. Maybe I'll say 3, okay? I'll give the
I'll
third.
give you 1 extra.
Okay. So I think the first thing is neuro is a black box to a lot of people. I would say the neuro exam, don't be afraid of the neuro exam, okay? Trust your instincts, your gut instincts. If a patient has a dilated pupil, trust that it is a dilated pupil, okay? Know to notify, know that, hey, the next step, there's only a certain few reasons why you would have a dilated pupil and non-responsive. Get that CAT scan, so trust your gut. That's number 1. Number 2 is in terms of seizure control. For seizures, the neurology department here is very good. If you're suspecting seizures and status, treat aggressively. Be aggressive. We're more likely to get in trouble because we undertreat with benzodiazepines versus overdoing it, because the thought in our head is, oh gosh, if you give so much benzos, we might have to intubate this patient. Actually, most studies say you don't give enough benzos, they end up seizing, you have to intubate the patient. And the third point I want to give is, I think Dr. Kevin and I were young to the program here, but we really want to build this neuro ICU program. We're always available. I think that's the third point we want to mention.
So just to reiterate what he said, number one, I mean, of course, after exhausting calling transfer center to try and get them to the neuro ICU, one of the things is neuroexamination. And even with the neuroexamination, you don't have to use fancy words like localization. Just describe what you see. Because once the patient can come up to the neuro ICU, or you can even give us a call, we have a better idea of kind of what's going on with the patient, and we can kind of guide that therapy. You can give us a call at any time. Sure. Yeah. So from the studies that we've actually that have been done, putting this patient in hypothermia, putting them down to 33 degrees, really actually has not really shown to benefit these patients. The focus is fevers make these patients worse, and that's one of the things that I think we do a lot very, very regularly is a patient, if you can imagine, you and I, if we have the flu, we're not quite ourselves. Now, if somebody has a brain bleed, a stroke, having a fever will deteriorate this patient's level of consciousness. But yes, it is not been shown so far to be neuroprotective. Next question, do you use mannitol or salt bombs regularly to treat ICH? So yeah, if the patients have increased intracranial pressure, certainly whatever is available. If the patient doesn't have a central line, we will use mannitol. If the patient has a central line, use hypertonic saline. And we certainly do, especially for the patients who have a huge hematoma that may have compression on the brainstem, edema, for example. Those are things that we regularly use.
And just to piggyback on that a little bit, make sure we know what the ICH, right? If the ICH is mostly intraventricular, there's no sense of giving mannitol, hypertonic saline. That patient needs an EVD, okay? So that's important.
What kind
when taking care of patients with increased ICP.
What kind of hemodynamic tools help you?
So a couple of hemodynamics. So the same thing that we use in all ICUs. We want to see art lines, right? We want to see their blood pressure, that's monitoring. We also, for ICP component though, what we actually do, well, we haven't done more, what we should do more, I should say, is to make sure if patients, what we say is pressure passive or not, means are they on the autoregulation curve or not? If we have an art line, we have an ICP monitor, we can actually make a patient's blood pressure go a little bit higher and see if we can get them back to that.
So there'll be a lot more questions will be coming in. We'll try to answer that after or later on. We'll go to the next speaker just so that we still in time, but certainly do not hesitate to pose more questions. We'll have Dr. Kevin and Dr. Anwar try to answer them afterward also. Okay. Thank you so much.
Thank you. Thank you.
Our next speaker is Professor Courtney Bruce. Professor Bruce is currently an associate professor at the Institute of Academic Medicine at Houston Methodist and an adjunct associate professor at Texas A&M Health Science Center. Professor Bruce has been awarded 4 local grants, served as a co-investigator on multiple federally funded grants, and has written over 65 articles in peer-reviewed medical, legal, and ethics journal. She has served as first author in over 50 articles, 2 textbooks, and 5 book chapters. She's a recipient of Norton Rose Fulbright Faculty Excellence Award in Enduring Education and Educational Leadership. Professor Bruce has served on the Ethics Committee for the United Network of Organ Sharing, and she will be addressing the topic on ethics based on new Texas DNR law, What Do I Do?
Thank you so much. Hi guys, how am I doing on volume? Am I all right? Good? Good? In the back? Okay. It's bad out there. You haven't been out there in the last few hours. It's really bad out there. All right. Clicker. Do I have a clicker? Is it this? Oh, that's interesting. Ah, thanks. All right, so this gives you some sense of where I'm headed today. I'm going to talk about a new law we have coming out on DNRs. And I would love to stand up here and say, we got it. We understand this law. We understand the implications of it. It's not going to impact you. No problem. That's not true. The law is a mess, and we really don't know the implications. We know it's going to impact you, particularly those of you who work in critical care, pretty profoundly. But I think we got a good grasp, so we'll see. All right, I'm going to give you some clinical ethics guidance on how to approach cases. I'm not going to go line by line through the law. It's very complex. It was written by lawyers, not clinicians. It was written by people that I'm pretty convinced have never met a patient, let alone had a conversation about do not resuscitate orders. It's really messy. My goal in the next 20, 25 minutes is to try to give you an approach for how to navigate these cases. And I've reviewed maybe 8 or 10 hospital laws in the area, hospital policies in the area. And they all seem to suffer from the same thing, which is that they don't actually tell you what to do. Like they don't tell you how to write the law, write the DNR in light of the new law. So my goal is to teach you the process. Like what do you do A to Z? How do you bake the cake ingredient by ingredient? That's my goal for you today, not to go by the law provision by provision. I will tell you I have not been fully supportive of this law. I've been pretty outspoken in your journals, actually. And a little bit in the media. So I'm not the biggest fan of this law, but I do also want to say that I don't think your conversations with patients about do not resuscitate orders is going to change. So if you leave here thinking, oh my goodness, my whole approach, my whole conversation is going to change, that's not the case. That is actually going to stay the exact same as you approach it now. But where you're going to see some differences is that now you're going to document it differently. You're going to have to do a lot more documentation, frankly. And you're going to have witnesses. So the process is a little different, but the conversation has not changed. All right, so what are we even talking about? In other words, what does this law even apply to? Inpatient DNRs only, not out of hospital. And DNR only, not other forms of life-sustaining treatment. So we're talking about cardiopulmonary arrest, respiratory arrest. What do you do with regard to resuscitation? Now, the ED, be careful if you have colleagues or know anyone who works in the ED. The ED is actually technically considered outpatient. So that's the out-of-hospital DNR order. This law does not apply to the ED, but here's the asterisk. Many clinicians in the ED do cover what sort of DNR a patient might want once they're actually transferred to the floor or to the ICU. If they're covering transfer orders, like what they want to see happen once the patient gets to the floor, or what the family wants to see happen once the patient gets to the floor or to the unit, that means this law governs, all right? So be very careful of the distinction. ED, outpatient. ICU, very much inpatient, as you would imagine. All right, and the implementation date of this law is right around the corner, March. All right, so why did we come out with this new bill? Or why did they come out with this new bill? For many, many years, we had this big law in Texas. It's the Texas Family Safety Code, 166. It governs just about everything pertaining to end of life, how to do an advance directive, your surrogate decision makers, who can make decisions about end of life, how to handle a dispute in the event of a conflict between family members. That was all governed in 166. But they never covered, they were silent on DNRs. That was the only thing they were silent on. It was like 15 pages of law. They were silent on DNRs. So several activists, professional organizations like Texas Right to Life, Texas Alliance to Life, those who tend to be really right to life, really aggressive when it comes to life-sustaining measures, they said, this law, 166, that you guys have had in place for maybe 10 or 15 years, and we really have had it in place for a long time, and it's a good law, it's silent with regard to DNRs. So that means that physicians could write a unilateral DNR. In other words, writing a do not resuscitate order over the objections of the family, or patient even, or without their knowledge, writing a DNR without consent. Now that's what they claimed, and they brought in all these anecdotal cases of folks that have claimed that to be the case. But are they actually accurate when they say that a bunch of physicians are out there writing DNR orders over the objections of the family or without their knowledge. In other words, are there that many unilateral DNRs out there? I don't see the data to suggest that's the case, and I've done pretty extensive reviews. The only study I can really find that maybe hints towards unilateral DNRs is the one that came out, I think, in Chest. I can provide the citation if anyone wants to see it, where 6% of all physicians, and I think they surveyed everybody across the gamut, not just critical care physicians, report writing a unilateral DNR order. But when you read the article fully, even those physicians report doing it very rarely and with the knowledge and agreement of the family. Well, then that's not a unilateral DNR. They might not like it, the family might not like it, but they agreed to it, they consented to it, right? That's not unilateral. So even in those 6% of cases, there was consent. So even if we were to assume that there's a whole bunch of data out there, which there isn't, but let's just assume that there's a bunch of data that this is a major problem, that physicians are writing DNR orders left and right over the objections of the family without their consent. Let's assume it's a problem for just a minute. Well, if it is a problem, what's to suggest that the legislature is the best vehicle to address this? Why do we need to create a law? Now, I'm not saying the legislature doesn't have a place in healthcare. It does, it very much does, but only when clinicians are unable to police themselves, to regulate themselves. So let's take surgical informed consent. For the longest time, surgeons were not, particularly surgeons, others as well, but surgeons were not disclosing risks, benefits, alternatives to surgery. Oftentimes, patients were going into surgery and having no idea what they were getting. I mean, there's literally decades of research that shows that. Geez, I really wish you would have told me that there was a risk of paralysis with this Lammy. I might not have actually moved forward. Just case after case. Finally, after decades of research and decades of lots of cases going to the courts, the legislature, both nationally and in our state, said, look, we gave you a chance. We gave you a lot of chance to regulate yourselves, and you couldn't do it. So now we're going to create a law. I get it. I get it in that situation. It's perfectly legitimate to have a law in that situation. In this one, though, you didn't even give them a chance to regulate themselves, assuming it's even a problem. So why did we jump so quickly to creating a new law? And again, let's assume there's actually a problem, that there's a bunch of data that suggests that physicians are writing a bunch of DNR orders over the objections of the family and without their consent. Even if that is true, why didn't they just stop at saying, if you're going to write a DNR order, you need consent from the family of the patient, period, and leave it? And there's like 11 states that have laws that literally say that. It's 2 sentences long. Why didn't they do that? Why didn't they stop at what they considered to be the problem? You should stop at what you consider to be the level of the problem. Instead, they spend pages and pages going through what your process in the hospital should be, and that's where I've got a real problem with the law. It shouldn't go into telling what makes sense from a clinical perspective and from an operational flow perspective. Because the only people who can govern that are people who actually work in the hospitals, who know this unit, who know how it flows. And these folks did not. All right, so what does the law actually say? Again, it's a mess. It's about 14 pages. It does not cover A to B or A to Z. It's bits and pieces here, so you got to kind of pull it all together. I'm going to go through 5 different scenarios real quick. And they're ordered in what I think is the likelihood of probability of you seeing them in your ICU. So we've got Alice here, and she's got her hands in her pockets, so she doesn't have any sort of written directive on her. She has capacity, or competent. We'll just assume those words are interchangeable. They're not really, but let's treat them as interchangeable. She has no family with her, but that's fine. She has capacity. She's good, right? She has no written directive. What do they even mean by written directive? They don't actually define the concept in the law. We think they're probably talking about a living will, like a living will where on the back in that additional instructions section, the patient wrote something like, I do not want to be resuscitated. We think that's what they mean by a written directive. But I also think what could also be applicable here is just a piece of paper where the patient wrote, I do not want to be resuscitated in the event of an arrest, signed me, Mark, and here are my 2 witnesses, and here are the date. Here's the date. That would actually be sufficient from a legal perspective, and I think it would actually be okay as whatever they consider to be written directive. But she doesn't have any of that. So we have Alice, she doesn't have any of that. Then we have Betty, and Betty is unconscious, she's incapacitated. She doesn't have a piece of paper with her, right? So no written directive. She has family, though. She has that gentleman standing over her. Then we have Kathy. Kathy is awake, alert. She's capacitated. She's doing really good. She has a piece of paper with her, a written directive, no family with her, but that's all right. Or even if she does have family, it doesn't really matter. We're turning to her since she has capacity. Then we have Derek. Derek has this piece of paper with him. So he has a written directive. He's unconscious. He's incapacitated. He has family with him. And then we have Eli. No paper, so no written directive, no family, and he's incapacitated, lacks decision-making capacity. So we're going to go through each of these scenarios. I think the Betty situation is the one they're really trying to target. The law is also trying to target the Derricks. So these guys are the ones I really want you to focus in on. And those are where there are new elements. A lot of these other folks, there are no real new elements, and you're going to approach it just the way you did before. Okay, let's start with Alice. How should you approach her? Talk to the patient about a DNR. Who is the person that should talk? Here's where it gets really sticky. The law actually says the responsible physician. Okay, who? And then if you, I'm not suggesting, wow, wait a minute. Y'all went to the totally different thing than what I was trying to say there. I was meaning, who does that act, when you've got 14 different people involved in the care, who actually is the responsible physician here? If you read the definition, it seems to imply that the responsible physician is actually the person on the addressograph, so the person on that little sticker that we have where it's got the patient's MRN. Uh-oh. Oftentimes, that's like a surgeon who hasn't seen the patient in 4 weeks, hasn't been involved. It's somebody that really isn't acting like the main gate, central player here. So what would I recommend in that sort of situation? To be consistent with the law, if you're thinking you really want to approach DNR and you're thinking you probably want to come out with the DNR, you would advocate for it or recommend it in cases where you think resuscitation would be medically inappropriate, I would talk to the person on the addressograph and try to see if you can get the name switched, which you can do very easily in Epic, to being somebody who knows this patient more, who can approach the DNR conversation comfortably, like an intensivist. Or maybe a hospitalist. Does need to be an attending physician. I would make an explicit recommendation. I don't like the framing, do you want a DNR? Why? Does anyone know why we don't like that? Just don't ask the question. Does anyone know why we shouldn't ask the question that way? Instead say, I would recommend a do not resuscitate order for this reason. Does anyone know why I prefer the recommendation versus the... Yeah, exactly. If you say, do you want a DNR? First of all, the families can be like, we don't know. You tell us what we need to do in this situation. And empirically, in the studies we've had, patients hate it. Families hate it when we frame it like that. They instead prefer an explicit recommendation. Plus, you're much more likely to get a DNR when it's appropriate, when you frame it like a recommendation rather than a question. Like the differences between like 80% success rate in getting a do not resuscitate order when it's appropriate, when you frame it in terms of recommendation, versus 20% when you frame it like a question. So serious difference. Document the patient has capacity. Okay, nothing new here, right? 1 through 4 is exactly the way you likely approached it before. Then if the family consents, or patient consents, she's capacitated, consents to a DNR order, you need to have 2 witnesses. One of those witnesses cannot be an employee of, and I have a typo here, it's actually the attending physician, cannot be an employee of the attending physician, and cannot be anyone who provides direct care. So if you're taking care of this patient, you cannot sign for it. A nurse on the other floor can sign for it. So this is where I'm like, oh gosh, what is this process going to look like? A volunteer with the hospital can sign it. Every hospital is sort of creating their own policy on what they want to be those witnesses and who you should approach. The one written here is by Spiritual Care. It's coming out pretty soon. It's a good one, actually. So you have to look at your own institution as to what they want to do for the witnesses. Cannot be anyone providing direct care. And if you work under the attending physician in any capacity, like you're taking care of the same patient, I wouldn't do it. It needs to be somebody totally not involved. Then you're going to inform the patient that since she's capacitated, that you have placed a do not resuscitate order in the EMR, and document that you informed her. Document that you informed her. I think you probably were doing 6 before, but I don't know that you put this, you probably put this part in, but you probably informed the patient that you placed a DNR, I would hope. You did that before, but you probably didn't document that you informed them. Now you need to do that. So 1 through 4, same as it's always been. 5 and 6, a little bit different. 7, patient can rescind at any time, even during a loss of capacity. That existed in the old law. Nothing new there. Okay, so only 5 and 6 are new. Then we have Betty. We've got to talk with the medical power of attorney, assuming there's a medical power of attorney document on the chart. We go to that person first, right, because the patient lacks capacity. If there is no agent, we go to the surrogate in the order of the surrogate hierarchy, first starting with the spouse and going to adult children. Yeah, shaking head, you know where I'm at there? Okay. Use the same communication skills as you did with Alice. Make that explicit recommendation. Then complete a DNR order. Again, need 2 witnesses. Cannot be an employee of the physician or anyone providing direct care. Inform the family that you placed the DNR in the EMR and document that you informed them. So 1, 2, and they can rescind at any time. So 1, 2, and 5 are just the same way as they've always been. No changes there. The only change here is 3 and 4. A shortcut for remembering this mentally is that any time there is no written directive, you will need witnesses. Anytime there is a written directive, you don't need witnesses because the written directive does the witnessing work for you. So that's the mental shortcut for how to think through these cases. Whoopsies. Kathy, so now we're on Kathy. She's competent, remember? She's got a written directive, maybe even a piece of paper that says, I do not want to be resuscitated. And she signed it, and she's got witnesses, and she's dated it, so it's legitimate. Still the same communication skills that you always used. But you don't need witnesses, again, because she's got that written directive. Remember the shortcut. When you got the directive, you don't need the witnesses. When you don't have the directive, you need witnesses. Again, inform her that you placed the DNR on the EMR and document you informed her. Nothing really new here. This is the way you were probably approaching the case before, except for that now you want to document that you informed her. She can rescind at any time. Nothing really new. We good so far? Any questions so far? Okay, good. Then we have Derek. Remember, the Derek and the Bettys are the hard ones. This one's really messed up. All right, so we talk with the MPOA first. We use the same communication skills, then complete a DNR. Again, he's got that paper with him. He's incapacitated. He has family. He's got the written directive. So we don't need witnesses because we have the paper. And he is incapacitated, so we're working with the family, the MPOA likely. And here's the kicker. If there is an agent, because there's actually documentation, a medical power of attorney, that agent not surrogates, so a wife that's not an agent can't do this. Only an agent can do this. Can override the patient's wishes for a DNR. They can technically override this document right here. Oh, dear gosh. This makes no ethical sense whatsoever. Because remember, the job of family members when a patient lacks capacity is to step into the shoes of patients and make decisions on behalf of what the patient wants, right? That's substituted judgment. You know that concept backwards and forwards. But now we're saying you could override substituted judgment. The family can say something that's totally inconsistent with what the patients wanted before. And if we're allowing them to override substituted judgment, we're violating a major ethical axiom. I do not understand how the law can be considered justifiable when it violates an ethical axiom that's been around forever. The other reason why, by the way, other than this provision, which I hate, another reason why I don't really like this law at all is why do you want witnesses involved in this very sensitive conversation about do not resuscitate? I mean, it's just totally inappropriate. So those 2 provisions, which are new, I think really takes the conversation in a direction we don't want to go. Assuming the patient didn't override the DNR order, the MPOA can rescind, and you must inform the MPOA that a DNR was written. Nothing new there. So number 4 is the new part. Eli, this is not really new. A lot of people say this is new. I think we've had plenty of evidence to suggest that this was appropriate even before now. You've got Eli. He lacks capacity. He's unconscious. He doesn't have family with him. He doesn't have any written directive on his body. He is sort of your lone patient, right? Your incapacitated, unrepresented patient. When you get him, and you want to try to use your social worker and case manager, social worker in particular, should use diligent efforts to reach family. It does not define diligent, I think. I'm pretty sure it doesn't. But just basically the same efforts she would use in any case to try to reach family. You document the patient's in a terminal or irreversible condition, which you did before. Then you can write a do not resuscitate order if it's appropriate, but here's the little new provision, which is new. The death must be imminent. Doesn't define imminent. But if you look at other parts of our old law, which is still in place, 166, imminent is defined as minutes to hours. So I think anything less than 24 hours, where you anticipate you're assuming the patient would likely die in 24 hours or less, would probably qualify as imminent. And you can write a DNR order if the death is imminent as long as there's concurrence from another attending not involved in the patient's care. That was in our old law, nothing new there. Both should document medical appropriateness. Social worker should document efforts to identify family. No witnessing or notification requirements here. All right, so how do I pull all of those 5 cases together? If there's nothing else you remember at all from my talk and you're like, oh goodness, she went through 5 different cases, I don't know that I can remember all 5 cases, remember this slide. Like print this slide, take a photo. I'm okay if you take photos. I'm actually okay also sending my slide set. You guys can send my slide set around, I don't mind. As long as you don't actually give the presentation without my name on it. I've seen a lot of that going on. Even on the internet, actually, where I'm like, that's my talk, and that's not me actually giving the talk. So where am I? Did I just, okay, so yes, this is a very important slide. It's the summary. It's the rules of thumb. If there's a written directive, any kind of written directive, it does the witnessing for you, and you don't need it. You don't need witnessing at the hospital for a new DNR. When you do not have written directives, you need the witnesses. So the rule of thumb there, if I've got the paper, I don't need witnesses. Inform in every case you can, except for when you have no one to inform. In the case of Eli, you didn't have anyone to inform, right? He's out of it, he's unconscious, he doesn't have family. You don't have anyone to inform. But in all the other scenarios that I went through, there was someone to inform. Start first with the patient, obviously, if they have capacity. Hey, buddy, I'm putting the DNR in the chart. When the patient lacks capacity, then go to the who? Before we get to surrogate, who comes first? Agent, medical power of attorney, assuming there's an actually medical power of attorney documentation, and ask for it. Just because they say they're an agent doesn't mean they are. Ask for the documentation. If there is no MPOA, then you inform the surrogates. When families create DNR, they can rescind at any time. When patient creates DNRs, they can rescind. That's it. That's the summary. The final reason I cannot support the bill, so the first reason is I really don't like witnesses in this conversation at all. I don't think it's appropriate. Second reason is the MPOAs are actually able to override the patient's preferences. I think that's a major violation of an ethical axiom. And the third reason I can't support this bill, and by the way, the Texas Hospital Association doesn't support this bill, is because, man, did they slam penalties on critical care physicians. They said, you can have a criminal misdemeanor if you falsify a DNR. And by the way, if you don't follow this law, we could take you to the Texas Medical Board. This is the first time they did that I remember. They do put in limited liability for physicians who act in good faith. What do we even mean by good faith? That's actually a legal term. It means acting in accordance with what any reasonable physician would do in your situation. So how do you prove good faith, or how do you show that you acted in good faith? Think, use good judgment, carefully document your rationale, talk to colleagues if you're confused, or maybe you're stuck on a case or you're not really sure what you should do in that situation. That's good faith. Using discretion, using good judgment, and showing what you did and why you did it. A couple of different tips. I'm going to close in this last minute or two. Every hospital is going to come out very differently. There's some hospitals that I've taken a look at where they're taking a very minimalist approach, where they basically say, we don't know what this law is going to do, so we're just going to kind of follow it, maybe. Then there are other hospitals that have taken a very maximum approach. There's one hospital here in the medical center, and they literally wrote like 4 different DNRs or consent law like forms, and I was like, I don't understand. I think I'm usually a pretty reasonably intelligent person, usually, but I was like, I can't understand any of this. So I'm pretty sure families and patients won't be able to understand that. Methodist, by the way, what approach are we taking? Using basically the electronic medical record to guide you through. So we've built in places in Epic that show exactly what to do, like the notification requirements are in Epic. The witnessing requirements are in there, where you actually have to write who your witnesses are. So it guides you through it. The second bullet point, all I mean by this is the more uncertain you are about how the patient or family came out with regard to the DNR, the more tentative they seem to be, the more evidence you want with regard to witnessing. Okay, so if they were just doing head nods, they weren't all that verbal about it, be careful with your witnesses, because you really want lots of strong witnesses and evidence when you're a little more tentative on the DNR side, okay? Take-home points, this is inpatient DNR orders. Watch for the Derek or Bettys. Keep in mind that a lot of the processes are the same for the other guys. Document your rationale and thought process very, very carefully. That illustrates good faith, so if there should ever be a lawsuit, which I'm hopeful there won't be, but if there ever is, that would be your good faith argument. There's still a lot we don't know. I'm pretty sure living wills are going to change. I think there's going to be a provision added to them about resuscitation specifically, so we'll see the implications of that. Your life-sustaining treatment order forms are going to have to change too for most hospitals. Follow your EMR. And then I think some of you guys have some assessments to do, so you can go through those. But if there are any questions, does it come up on the screen?
They will pose questions.
Okay. So should I wait?
You can start reading the question.
Die within 24 hours of imminent death.
Ooh. Oh, I see them. What if a patient doesn't die within 24 hours? That's fine. It's based on prognostication. Obviously, you can't be clinically 100% sure in your prognostication efforts. We're actually not all that accurate in prognostication. So just while you're thinking of imminent death, just document that you anticipate that death would be imminent. And if it turns out that it isn't, that's fine. Is it better for nurses to never witness a DNR? Even if I'm not the nurse today, I could be tomorrow. Wow, I was hoping I wouldn't get that. Kudos to whoever actually put that. I'm going to be really frank with you. We're going to have to turn to nurses that are involved, that are not involved in the patient's care to help as witnesses, because it's so hard to go out to a random family member that's not at all involved in this patient's care, who doesn't know you, and pull them in. It's much better to pull in at least somebody who's got some idea, which would be a nurse. So we're going to be pulling on you. Do I like it? No, but it is. I'm a night shift, dang it. If a patient or MPO makes decisions for DNR overnight, can I place the DNR order so it's in the Epic banner and have the attending co-sign in the morning? I wouldn't. But we'll see. Every hospital is going to have a process for that. So I wouldn't, just from a risk management perspective. If a patient specifically states on their established DNR cannot be rescinded by the MPOA, could the MPOA still rescind? I don't know. I don't know. Man, you stumped me there. I think it'd be really, really hard for the MPOA to argue that they're at all following patient preferences, but I don't know. I really don't know the answer to that. Can residence fellows do any of this? You can have the conversation. You can't do the documentation. What are the legal implications for the non-employee witness? Oops, that's gone away. Should they have legal protection by the institution? They don't have legal protection. I'm sorry, I don't think. Where does medical futility fall? There's no way I can answer that in a couple of minutes. Where does medical futility? Medical futility falls to the extent that if you think a do not resuscitate order is the most appropriate for your patient from a medical perspective, then I would still approach the conversation and do it just the same way you did before. Just document it a little differently. Did I get all of them? Hospital volunteers are not the best group to pull on these. Yeah, I know they're not the ideal group at all, but I can't think of who is the ideal group. It's probably not a family member who doesn't even know this patient who's trying to grieve and deal with their own family responsibilities. I feel like volunteers might be more equipped, but no, they're not the best, nor are nurses, nor is anybody. That's why I can't stand the witnessing requirement. This is just so awkward. Did I get them all?
I have a question.
Yeah.
Sorry. So with witnessing, is the witness documenting that they saw the yes or the no? Or is the witness documenting understanding of the DNR? And I say this, for example, like if I'm in a lawyer's office and signing my last will and testament, the witness is just documenting that I am who I am and I signed my signature. They're not documenting
Yeah.
anything that's in it, right?
Uh,
So in
and-
that case, the witness to the DNR could be the unit secretary, could be anybody if they're just documenting the person's identity.
They're
and
documenting
statement.
that they were part of the conversation and that is indeed what the patient or family said. That's what they're documenting. I know. I didn't say I like this, guys. Yes, I know.
Take my stuff.
Thank you very much, Professor Bruce. Our next invited speaker is Dr. Cristina Gutierrez. Dr. Gutierrez has dedicated herself to the care of the critically ill cancer patient since her critical care fellowship at Memorial Sloan Kettering Cancer Center. After successfully completing fellowship, she joined the Pulmonary and Critical Care Department at New York Hospital, Queens, as Assistant Clinical Professor and Associate Residency Program Director for the Internal Medicine Program. There, she was a recipient of Teacher of the Year Award for 2 consecutive years. Since her move to the University of Texas MD Anderson Cancer Center, she has focused on clinical research on critical care complications associated with immunotherapy, and specifically the CAR T-cell patients, on which she had a recent publication in Critical Care Medicine Journal. She will be talking to us on the topics of management of critically ill adult CAR T-cell therapy patients, a critical care perspective.
Thank you. So I want to thank everybody for having me here. And I know this is a topic that is very specific for the oncological patient. But we thought that it was important for us to put this out there because I think more and more people are going to start seeing these patients in their ICUs and not only on big centers, but I think we're also going to start seeing these patients in the community. So let me see. Yes. So the objectives, we're going to talk a little bit about the 2 major complications that these patients are going to be presenting to in our ICU. We'll discuss the treatments that we have available so far for both of these complications. And I also want to sort of focus a little bit more on how important it is to first treat these complications very, very quickly, but at the same time make sure that you're ruling out any other complications that you might actually have in patients with malignancy and that are admitted to the ICU. So you've got to treat many things at the same time. So when you talk about CAR T cells, they are part of what we call immunotherapy. It's a rapidly expanding area in the cancer treatment with very good outcomes. And you can divide it probably into monoclonal antibodies and immune effector cells. And when it comes to immune effector cells, you can talk about TCRs that we use mostly for solid tumors. They don't have as much toxicities. At the same time, they have not shown that great outcomes. So we're not going to talk about them. But we will focus on the chimeric antigen receptors. So these are what we call CARs. And when you talk about CARs, these are mainly autologous and T cells. But there are some studies out there right now, some protocols on allogenic cells and other types of cells such as natural killers. And when you think about the CAR T cell, what you're doing is you're taking the T cells out of the patient, you're sending them to the company, I guess, or to the lab. And over there, what they're doing is they're actually modifying the cell so that they express an antibody. And this antibody is going to be specific so that they target a specific antigen of whatever the malignancy is. The most common one that we have is the CD19. This is the one that has been approved by the FDA. And what it does is it targets the CD19 antigen, which is what we see in patients with B-cell malignancies, such as lymphoma and leukemia. 2 products have been approved so far by the FDA, but I do think in the next couple of years we're going to be seeing more and more products being approved. One by Kite, which we're treating B-cell non-Hodgkin lymphoma, and the Kymriah that we're actually treating patients with B-cell leukemia and also lymphoma. And as you can see in this table here, the amount of protocols and studies that we're seeing every year is just growing exponentially. So you're going to, at some point, see some of these patients in your units. And I guess one of the things that I want to really talk about is what's the hype about this and what does it make it different from any other protocol out there when it comes to patients with cancer. It's that these patients are doing really, really, really well with these treatments. So when you think of the patients, the pediatric populations, you're talking about patients that have failed multiple lines of therapy, they usually only have less than 10% survival. But the patients that have been treated with CAR T-cell therapy, more than 80% of these patients had an initial clinical response. And at 3 months, more than 63% of patients were free of disease. And we have patients now that are 4 or 5 years out and are still free of disease. When it comes to the adult population of patients with lymphoma, these are patients that had, again, failed multiple lines of therapies. Their survival was less than 15%. We were already talking about hospice care for these patients. 70% of these patients had some response after CAR T-cell therapy. More than 50% had complete response, meaning they had no evidence of disease. And we just have recent data of 2 years after CAR T-cell therapy, and about 50% of these patients are still free of disease. So this is really significant, and it's important, and we think it's an area that it's actually going to be exploding at some point. And these are sort of PET scans of patients being treated after CAR T. So it's really impressive, the responses that we're seeing. Now, even though they're responding so well, the problem is that we're having really significant toxicities. And a lot of these patients are ending up in the ICU. And this is why it's important for all of you to actually know what's going on. The most common ones that we're going to talk about, there's definitely more toxicities, but it's cytokine release syndrome and neurotoxicity. And one of the things that I also want you to take from this talk is that talking to the oncologist in the care of this patient is going to be extremely important. And the reason is because we know that every product varies significantly. And the amount of toxicity that you're going to have, how fast it's going to be, the medications you should be using to treat these toxicities is going to vary depending on the product. And this has to do, with the cell dosing, how the time of culture, the media, the vectors that were used, and even the conditioning chemotherapy that was used. So let's start with cytokine release syndrome. So it's the most common toxicity. More than 90% of patients with lymphoma have it. More than 80% of patients with leukemia will have it at some degree. And what I want you to see is that grade 3 toxicities can be as high as 13%, but this doesn't include those patients that were on low-dose pressors. So you can say that about 20 to 25% of patients will end up in the ICU with cytokine release syndrome. What is it? So what usually happens is you infuse the cell into the patient. The CAR T is going to recognize the antigen. It will get activated, and it will start proliferating. Usually within 5 days, this is when you're going to start seeing the peak of the proliferation of the CAR Ts. And this is going to cause, yes, local inflammation starting by the CAR Ts, but also it's going to lead to activation of other inflammatory cells. So you're going to have T cells, macrophages, dendritic cells that are just going to start proliferating, and it's going to just be exaggerated and very severe. The higher the CAR T proliferation, the more severe your CRS, and most likely that your patient is going to have a good tumoral response. However, we have had patients that have had no cytokine release syndrome or just like mild fever, and they still had some tumor response. When it comes to the cytokines, we see that most of the cytokines actually are increased when you talk about cytokine release syndromes, but there are certain ones that we know that play a very important role. The first one is IL-6, interferon gamma, IL-10. IL-1, we're also starting to see that it plays probably a significant role. We're going to see elevation of CRP, ferritin, and MCP1 and GM-CSF is also going to be elevated. So what is difficult about cytokine release syndrome is that, yes, there are certain things that will actually help us think that this is just related to CRS on its own. But it just presents with multi-organ failure, which in a patient with cancer, it can be anything. And that's what makes it so difficult to sort of treat and to make sure that you're not missing anything else. Now, the most common symptoms that you're going to be seeing are fever, hypotension, and hypoxemia. And they're so common that at this point, we used to use pretty much every organ toxicity to define whether or not if it was a grade 1 versus a grade 4. But we have now a national consensus that just came out, and they're just focusing on only these 3 symptoms as the most important ones and the ones that we should be using for toxicity. So when it comes to the hypoxemia and the respiratory insufficiency, you can have patients that will develop some pleural effusions. Usually they're just mild. And this is all just sort of in the setting of this inflammatory process and a capillary leak syndrome. Your patients will be developing some pulmonary edema, usually non-cardiogenic pulmonary edema, again, secondary to this capillary leak syndrome. And what is important, I guess, for all of you to know is that these symptoms progress very, very quickly. So you'll have a patient that in the morning will be on nasal cannula, and by the afternoon, they're already going to be in full-blown ARDS, and you're going to be intubating these patients. So always keep a close eye on them. When it comes to the cardiac toxicities, the most common thing that you're going to have is hypotension and shock. The majority of patients usually fall within just being slightly hypotensive, responding to IV fluids, or requiring low-dose vasopressors. But we have had patients that have ended up on 3 vasopressors, inotropes, because some of them also develop a cardiomyopathy. This cardiomyopathy is very similar to sort of like to our septic cardiomyopathy, stress-induced, and usually resolves as the CRS resolves. Arrhythmias are also common. Tachycardia is probably the most common ones, but we have had patients with runs of VTAC, AFib, so it's important for all of you to keep an eye on this. And pericardial effusions, usually mild. We haven't really seen that many, but just keep it in the back of your mind. When it comes to renal toxicities, they can develop acute renal failure from the CRS on its own. Usually doesn't present as a sole toxicity. It's usually associated to just a patient that is in multi-organ failure. It is important to know also that these patients can develop tumor lysis syndrome if they have a lot of disease. So also keep that in the back of your mind, and you're going to have a lot of electrolyte abnormalities. Some patients will develop liver failure, skin lesions that can be severe and very diffuse. And lastly, DIC. The reason why I want to bring up DIC is because we're also seeing that DIC is kind of like a marker of severity of disease. And those patients that have usually a grade 4 CRS or neurotoxicity are usually patients that are also presenting with DIC. So this is the most recent grading. The manuscript just came out like 2 weeks ago, so I made sure to include it, and it's a little bit different from what we published. And I guess one of the nice things about this is what they did is they made sure that everybody with a grade 3 or grade 4 should always go to the ICU. That's sort of what you have to think about. Grade 3 is anybody with vasopressors, and when you think about it, it's interesting that we are considering patients with just high-flow nasal cannula as a grade 3. You think like those patients are usually not that sick, especially when you're thinking about your oncological patient. Everybody's on the floors on high-flow nasal cannula. But these patients, we want to make sure we bring them early to the unit. So once that you're thinking about putting them on high flow, you should immediately bring them to the ICU. If you're thinking of BiPAP, probably just skip the BiPAP and you might just intubate these patients. So some of the other general considerations I want you to have is make sure that you're also ruling out any other causes of either the respiratory failure, the renal failure, the shock, These patients can still have an acute coronary syndrome. They can have cardiac tamponade. And most importantly, neutropenic sepsis. All of these patients have received heavy doses of chemotherapy. So as soon as they have fever, make sure that you treat them with broad-spectrum antibiotics because a lot of them do end up developing infections. Hemodynamic monitoring is going to be very important. They all have capillary leak syndrome, so you want to make sure that you're hydrating them well, resuscitating them well, but that you're also not overloading them. Make sure you evaluate what your heart is doing. You can do bronchoscopy to see whether or not if there's an infectious process, viral pneumonias, diffuse alveolar hemorrhage, and imaging. Now, when it comes to the role of cytokine CRP and ferritin, whether or not if it's useful for the diagnosis. So it can guide us somehow. We know that these patients have elevated CRP and ferritin, but at the same time, we'll know they're very nonspecific. So anybody who's severely sick, anybody with cancer are going to have elevated levels. But just the trend might actually give you a little bit of information. When it comes to the cytokines, I think there's a lot of limitations when it comes to the cytokines. First, availability. Not every hospital has availability for them. The other thing is the turnaround. It usually takes about a day for the cytokines to come back. And at that point, you should have already treated this patient aggressively. And lastly, we're getting more and more data in which we're actually seeing that patients who have documented infection, post-CAR T, and those that don't, and we suspect that it's only CRS, there's really no difference in the cytokine levels. So it might be that they actually don't help us to actually make a diagnosis. Now, the other complication that we have is neurotoxicity. We used to call it CREST. Now the new terminology is ADCANS. Extremely common. More than 80% of patients will present the neurotoxicity. And what's most important is that, look, more than almost 50% of the patients will develop a grade 3 toxicity. So these are all patients that are going to be coming to the ICU. So it's very important for you to know that. It's usually biphasic. CRS just presents sort of once in the majority of cases. When it comes to the neurotoxicity, you'll have sort of a first phase that will show up in those first 5 days when CRS is presenting. And then you'll have some other patients that will develop it later on, sort of like around day 10, day 14 or so, on their own without any CRS whatsoever. We're learning more about the pathophysiology, but it's still very interesting. We still don't know exactly what is actually causing it. We definitely know that none of these patients have any evidence of CNS disease, so it's not related to that. We're actually treating patients with CNS lymphoma, and it doesn't really correlate whether or not if they're going to develop neurotoxicity. But thinking about the CRS and how the CAR T sort of behave, we're thinking this is, again, an inflammatory process. So your CAR T start proliferating, you have all these cytokines, all of these inflammatory mediators. This is going to cause some endothelial dysfunction in your blood-brain barrier, increases the permeability, and then you're going to start having this influx of inflammatory cells. We're seeing CAR T cells in the CSF of these patients. When they've done autopsies, they've also seen CAR T cells in the brain parenchyma of these patients, and we're seeing elevated cytokine levels in their CSF. So it's probably all just associated to an inflammation. Some risk factors, patients with pre-existing neurological conditions are probably at a higher risk of developing grade 3 or grade 4 neurotoxicity. A number of CAR T cells are also important, and also if you have especially in leukemia patients, a high percentage of blasts, you're at a high risk of developing grade 4 neurotoxicity. Now, what makes the neurotoxicity different from CRS is that it's very, very typical. It's very easy to diagnose, and it's just once you see one patient, you're going to be able to recognize it. So when it comes to the mild neurotoxicity, these are usually patients that are going to start having some staring, a lack of attention, some smacking of their lips, a little bit of tremors, headaches right at the beginning, and they'll have a little bit of aphasia, so some difficulty with word finding or just sort of difficulty communicating and sort of like slowed. Some patients will be agitated, some patients will be somnolent, and the most interesting thing is sort of the changes in the handwriting. So this, what you're seeing here, is a patient that completely asymptomatic on day 4. Day 5 starts developing the neurotoxicity, and even before any of the other symptoms like aphasia or anything else showed up, they already start having changes in their handwriting. And as soon as you treat them, this resolves completely. So taking that into account, this is one of the things that we actually use as a monitoring tool. We also sort of have this CAR-TOX score that also takes into account, some of the other symptoms. Now, what is relevant for the ICU physician is probably more of the grade 3 and the grade 4 toxicities. So when you talk about the grade 3 patient, these are patients just with global aphasia. They can be either severely delirious and agitated versus obtunded. And we do see a lot of patients, once they have seizures, that's immediately a grade 3. Now, we do see that a lot of our patients with maybe grade 1 or grade 2 neurotoxicity, those are just sort of like staring. When you do EEGs on them, about 40% of these patients are in non-convulsive status, are having non-convulsive seizures. About 10% of patients end up having status epilepticus. So it's always important to do an early EEG on any of these patients as soon as the symptoms start presenting. Seizures, they can also present with convulsive seizures. And when it comes to the grade 4, patients are comatose, they can have status epilepticus, you can have paresis, which usually resolves once you treat, and cerebral edema that we'll talk a little bit more. So when it comes to the cerebral edema, this is probably one of the areas that is more worrisome when it comes to the neurotoxicity of these patients. There's been 6 cases of patients that have died from this complication. Most of them were leukemia patients. It was associated to one sole product, but we have had cases of patients with lymphoma, just one, who actually died from cerebral edema. None of these patients had any evidence of CNS disease. And what we're sort of finding is that a lot of patients actually do develop some degree of cerebral edema. Many patients will have more findings of just something more localized, more like a cytotoxic sort of local inflammatory process. And as you see here in the MRI, a lot of them we've seen a lot of them like in the thalamus. Posterior fossa is also very common, also in the pons. So maybe those patients with posterior fossa, pons, cerebral edema, you gotta be a little bit more careful, keep a closer eye on them, maybe be a little bit more aggressive. You will also find patients that have just diffuse cerebral edema. And these are the patients that are more concerning and that you probably have to be more aggressive. The treatment is really medical. Yes, we have to treat the neurotoxicity, and we'll talk a little bit more about those the specific things about it, but we have to sort of just keep an eye on, temperature, make sure that your blood pressure is adequate and that your patient is having adequate cerebral perfusion. If your patient is hyponatremic, make sure that you bring that sodium up, or patients maybe with diffuse cerebral edema, just make sure that you're running some hypertonic. I think the role of EVD or doing LP on these patients, it's very limited. A lot of the patients that we're seeing with severe neurotoxicity are usually in DIC or they're severely thrombocytopenic. So that's really limited, the amount of invasive procedures we've been able to do with them. So we've just sort of been able to do just medical management, really. When it comes to MRI versus CT scan of the brain, we do know that our MRI is picking some of these early signs of edema. However, it's very difficult in those patients, especially with grade 1, grade 2 toxicity, to be able to have them stay still to do an MRI. So always make sure to do a CT scan. It will also help you rule out any other possibility causes of changes in the mental status. Remember, they're in the IC, they're quite thrombocytopenic. We've had multiple patients with intracranial hemorrhages, a couple of cases with ischemic stroke, so always make sure that you do an initial CT scan of the brain. Because of the high incidence of seizures, we do seizure prophylaxis with Keppra on these patients. And we know that a lot of our patients, they usually respond just to some doses of benzos, increasing the Keppra, and that's the way we're able to treat the majority of our seizures. You should be keeping a close eye on these patients, monitoring, multiple times a day. And I guess most importantly is to have actually some clear-cut guidelines on how you're going to manage these patients once they develop seizures, once they develop status epilepticus, or if they have any cerebral edema. So the treatment specific for the CAR-T toxicities, so the first one is tocilizumab. So when I was talking a little bit about cytokine release syndrome, talking about all of these cytokines just sort of increasing initially. And one of them that keeps on being very elevated is IL-6. So this tocilizumab is a monoclonal antibody that what it will do is it will bind the IL-6 receptor, sort of blocking some of this. We recommend it for patients with CRS. If your patient has only neurotoxicity, we know that toci does not work at all. So only use it if your patient has CRS. And you should be using it for anybody with grade 2 or above. It can cause anaphylaxis, so keep an eye on that. And it's unclear whether multiple dosing actually plays a role. I think with the initial patients, we were giving it even up to 6 times between a course of the first 3 days, 8 times. But now we know that at some point, it binds to the receptor. So at some point, you're going to have saturation of the receptor with this medication. And the inflammation is just going to continue. So if by the second dose, third dose, your patient is not responding, just move to another type of therapy. The other type of therapy we have that we use is corticosteroids. So when you think about it, all of this is just an inflammatory cell, a process from these CAR T cells that are just being activated. So the idea of using corticosteroids is that they're somehow just going to shut down slightly these, their proliferation and decrease a little bit some of this inflammation. We use it on patients with grade 2 CRS that have not responded to TOSI, or anybody with grade 3, grade 4 CRS. If anybody has any toxicity that is grade 4, you should already be talking about pulse-dose steroids. We do know, however, that patients with neurotoxicity respond very, very nicely to corticosteroids. Even just one dose and it resolves. Which one to use, we don't know. We've sort of been just randomly using Decadron initially, low doses. They're not that low, 10 milligrams Q6, Q4. And then as the patient progresses, at the end, we're talking about Solumedrol 1 gram a day. And for how long to use it, we also don't know. It just sort of depends on how your patient is responding, and then you start decreasing the dosing as needed. We do know, depending on the product, we do know that it does suppress a little bit the CAR T cell proliferation, but what we have seen is that even patients that have been on pulse-dose steroids for even up to a week, we have had patients that are in complete remission. So we're a little bit more aggressive about using steroids early to try to avoid patients just going into grade 3 and grade 4. Other treatments that are probably not FDA approved yet or that we only have animal studies. So siltoximab is another medication that we use. So if you've used TOSI and it's not working, you could still think that the IL-6 is still circulating, and siltoximab will bind actually to this IL-6. We don't really know. We don't have data to support its use, but it's one of the medications that we've been using. Anakinra, it's a blocker of an IL-1 receptor. It's been used in animal models. We've already used it in about 4 or 5 patients. Worked in a couple, not in some others, so we'll just have to see. Linsulimab, it neutralizes GM-CSF. It's only on animal studies, but we're starting to think about using it on patients that have refractory CRS. And ATG and suicide genes to completely shut down the CAR T cells if need be. So in conclusion, CAR T cells and other cell-mediated immunotherapies are promising therapies for the oncological patients, and you will start seeing these patients in your units. It's important to recognize these toxicities early, don't delay the treatment, and make sure that you have guidelines in your institution to treat all of these patients. Any questions?
How long do you put these patients in the hospital after they get the CAR T cell? And then what are the alerts you have on the floors? Because it looks just like sepsis, and how do you differentiate?
Yeah, so I think patients staying in the hospital, this is probably something that we're working on and trying to see if we can move these some of the protocols, I guess, to outpatient. But because of the toxicity, we've seen that patients actually end up staying in the hospital up to 2 weeks. Those who do well, maybe a week or so, but usually around 2 weeks. But we do have a lot of insurances starting to say we're not going to be paying for all of this. So that's going to be one of the problems that we're going to be facing. Now, when it comes to, about the symptoms being very similar to sepsis, yes. And we always sort of make sure that we're treating neutropenic sepsis on every single one of these patients. And so that's one of the most important things, to make sure that you treat it. We do have some sort of guidelines on patients who are high risk. We make sure that the physicians that are going to treat those patients to let the ICU know, so that we can actually transfer these patients fairly quickly to the unit. And I think education of the people on the floors and also the ICU teams has been extremely important. So we know that these patients deteriorate very quickly, and we probably bring them faster to the unit than we would any other patient. And the reason is because we know that they just get sick so quickly that it's better to bring them early rather than later. So multiple. So when it comes to immune effector cells therapy, CARs and also TCRs, So most of the heme malignancies actually, so we have multiple myeloma, all of the leukemias, all of the lymphomas. When it comes to solid tumors, I think the responses have not been that great, but we have GU, sarcoma, head and neck cancers, thoracic, so pretty much every malignancy is actually sort of going out there and trying to get treatments. When it comes to the monoclonal antibodies, it depends on the monoclonal antibody, but I think, again, most of the solid tumors are the ones that are usually treating monoclonal antibodies, and the toxicities associated to that are probably very different. So we're using more hypertonic than mannitol, and the reason is because we know that a lot of these patients that have increased ICP and brain edema are usually also presenting with severe CRS, not all of them, but a lot of them. And we're afraid of what it might do to the hemodynamics on these patients that are already in shock. So we try to usually just use hypertonic and try to elevate the sodium. Can non-oncologists order tocilizumab? Yes. So the thing about, and I think it will depend also in your institution about what the pharmacy sort of does to make sure that you can actually use it in the institution. But we've sort of made these order sets so that the TOSI is available for anybody just to order it and release it, but always talking to the oncologist that is taking care of the patient. Differentiation syndrome. I'm not sure about the differentiation syndrome, so I can't answer that question. No, thank you.
So we are going to move on to our next speaker, Annette D. Lister. Annette has earned her BS in Pharmaceutical and Healthcare Studies and her PharmD at the University of Sciences in Philadelphia in 2014. She completed a PGY1 pharmacy residency at Einstein Medical Center in Philadelphia, followed by a PGY2 critical care pharmacy residency at Houston Methodist Hospital. She recently earned her board certification in critical care pharmacy and is now serving as neurosurgical ICU critical care pharmacist. During her professional career as a pharmacist, she has placed emphasis on education of healthcare professionals and coordinating the PGY2 critical care pharmacy residency at Houston Methodist. Today, she will be summarizing the literature review 2018 updates in critical care. Annette?
Hello. Okay, can you hear me? Okay, great. Nothing like a riveting literature review right before lunch. I was really blessed to have the last lecture right when everyone's getting really hungry, is ready for more coffee, and then really excited about all the workshops. So, the clicker? Is this the clicker? Yeah, that's okay. Big green. Big green. Okay, so it was really difficult to pick what literature I wanted to review in 2018 because there was a lot of really great literature that came out. I feel like I'm a walking advertisement for New England Journal of Medicine because my last slide has about 10 other studies that I think would be really great and really applicable to changes in our practice today. And I didn't know if I should do a rapid review or I should do something more like a journal club. And as I was reviewing my presentation yesterday, I realized I picked the Delirium article that our keynote speaker was the last author on. And I was like, oh my God, I have to criticize his article in front of his face. But luckily he left, so we can critique it. And I'll go on and move forward. I have nothing to disclose. So my objectives are to evaluate the effects of haloperidol versus ziprasidone on delirium, criticize the utility of adjunctive glucocorticoid therapy regimens in patients with septic shock, and then appraise the mortality effects of proton pump inhibition for stress ulcer prophylaxis. So first off, delirium. As you guys already know, and just he pretty much did my whole lecture, at least this part of the lecture for me already. We know that delirium is the most common manifestation of acute brain injury or dysfunction during critical illness. It's described as an acute confusion state characterized by an alteration of consciousness. It could be hyperactive, where the patients are fighting with the nurses. It could be hypoactive, where the patients are not coordinating with the care of the nurses. And it could also be mixed. So we know that patients with delirium have higher mortality, longer periods of mechanical ventilation, longer periods of hospital stay, higher cost to our healthcare system, and higher risk of long-term cognitive impairment. So as what was previously mentioned, the ABCDE bundle has a ton of literature supporting its use in improving decreased mechanical ventilation, shorter ICU stays, a better mortality benefit. And this really is a bundle that supports what we do in critical care, which is working together as an interdisciplinary team with physicians, respiratory therapists, physical therapists, nurses, pharmacists to really improve and decrease the mortality of our patients. So we have a lot of nice drugs that we like to use. Haloperidol, probably the most common. In our unit, which is neurosurgical ICU, we like to use a lot of quetiapine. However, all these antipsychotic agents, as with any drug, have side effects associated with it, which I included here just for reference. Haloperidol, as well as ciprasidone, have the highest risk for QTc prolongation, which is something to keep in mind as we're viewing both of those drugs with the MIND USA trial. So the question that the trial wanted to ask was, among critically ill patients with hypoactive or hyperactive delirium, does the administration of haloperidol or ziprasidone improve the number of days alive without delirium or coma compared to placebo? So this was multi-centered, huge trial, double-blind, randomized, placebo-controlled, looking at haloperidol versus ziprasidone versus placebo, and it included patients, as previously mentioned. These were the common doses that were seen, and the primary endpoint, like I said, was number of days alive without delirium or coma. And if we look at the median days alive without delirium or coma, we can see that there is no difference between placebo versus haloperidol versus ziprasidone. Adverse effects, over sedation, actually there was really no difference between any of the drugs. Prolonged QTc, also very interesting, no difference among the patients. Torsades, no difference, and as well as neuroleptic malignant syndrome. So in conclusion, the use of haloperidol or ziprasidone as compared to placebo in patients with respiratory failure or shock with delirium did not significantly alter the duration of delirium. But we do have to criticize this trial a little bit, because do we just stop using antipsychotics altogether? Do I deny every nurse their Seroquel or haloperidol for their agitated patient? Well, a high proportion of the patients here had hypoactive delirium, which we already know is the most difficult delirium type to treat. So patients may have a less likely benefit from antipsychotics compared to patients who have hyperactive delirium. And not in my unit, I don't really use ziprasidone. We kind of fave Seroquel. Our patients tend to have prolonged QTCs already. So we really don't use ziprasidone that much in practice anyway, which is a really interesting antipsychotic that they chose to compare to haloperidol. Moving on, glucocorticoids and septic shock, which is kind of like beating a dead horse with a stick, right? Because we have so many major landmark trials that come out because they all conflict each other. So then we keep studying it. So we know that in septic shock, our body has reduced cortisol production or reduced cortisol breakdown, prolonged half-life of circulating cortisol due to renal dysfunction, diminished plasma concentrations of cortisol, binding hormone and albumin, inflammatory cytokines now have increased glucocorticoid receptor affinity, disabled glucocorticoid activation, and increased peripheral conversion of precursors to cortisol. So there's a lot of theoretical benefits to septic shock, and as a pharmacist, we like to talk about all the mechanism of action and pharmacology and all these theoretical benefits with medications. So there are a lot of things that steroids can do, which obviously is decreasing inflammation, that could help in a situation where a patient is in septic shock and is hyperinflammatory. So the Anand et al. Trial in 2002 was the first trial that looked at hydrocortisone and fludrocortisone versus placebo, and it actually showed a mortality benefit at 28 days. So when this came out in 2002, we all decided to adopt the use of steroids in patients with septic shock because this will help improve their lives. Then in 2008, the Corticus study, fairly big study as well, decided to look at hydrocortisone alone, which is kind of what we do in practice right now, versus placebo, and showed no difference at 28 days for mortality. However, if we point out, there is a shortened duration of time to reversal of shock, which was statistically significant. However, no difference in reversal of shock. So now we have two conflicting major landmark trials, and we're like, okay, now what do we do? So Hyperis in 2016 came out, and it looked at hydrocortisone plus a continuous infusion versus placebo, showed no difference in resolution of septic shock at 14 days, and really no difference in mortality at 28 days. So when do we use steroids? It's kind of like a last-ditch effort, right? We have a patient who's septic, in septic shock, adequate fluid resuscitation. Now they're not responding to their vasopressors. This is when we're using it, right? This is a very last-line agent just because we don't really have good evidence supporting the use of steroids. So two big trials came out for steroids. The adrenal study, which is a very clever name, in patients with septic shock requiring ventilatory and vasopressor support, does a continuous week-long infusion of hydrocortisone improve mortality at 90 days when compared to placebo. So also a nice, beautiful, large, multi-center, double-blinded, parallel group controlled study looked at patients with septic shock. Here, our hydrocortisone dosing is a little weird. We don't really do this. Continuous infusion versus placebo, and death from any cause at 90 days. Well, comparing the two, really no difference. Death from any cause at 90 days, no difference from patients who received steroids versus those who did not. Something that was statistically different, however, was the median time to shock reversal, which is something that the second study had also demonstrated as well. Adverse effects were slightly a little bit more significant in the hydrocortisone study versus placebo. So they concluded that in patients with septic shock on mechanical ventilation receiving vasopressors, a week of hydrocortisone continuous infusion did not reduce 90-day mortality and may be associated with time until reversal to shock, time to extubation, length of ICU stay, and blood transfusion. So what were some criticisms of this study, though? Well, adverse events and appropriateness of antimicrobials, which are really important in septic shock, were not examined and were kind of just recorded based on the clinical judgment of the researchers. The trial excluded those who had received etomidate, which we know has adrenal suppression. So this is something that we really care about in our patients who are ventilated and receive etomidate. And then prior trials used bolus doses of corticosteroids, given the importance of that rapid reversal of shock. So the authors thought that if I do a continuous infusion, my patients are going to have less hyperglycemia, and it may improve the anti-inflammatory response for these patients. So at the same time, in the same volume and publication, the New England Journal of Medicine, they also published the Approaches study, which looked at in adult patients admitted to critical care, does low-dose hydrocortisone plus fludrocortisone for 7 days affect mortality at 90 days? Also, a nice, large, double-blinded, multi-center randomized trial. Patients who had septic shock, they received their hydrocortisone plus fludrocortisone versus placebo with a 90-day all-cause mortality as their primary endpoint. Well, when we compare it, it looks like placebo versus hydrocortisone plus fludrocortisone actually showed a mortality difference. Now what do we do? So other things that also were shown in the study was all-cause mortality at 28 days, almost statistically significant, all-cause mortality at ICU discharge, statistically significant, and all-cause mortality at hospital discharge, statistically significant. So there's no difference in serious adverse events, bleeding, rate of infection, new onset sepsis, or neurological sequelae. So now we have two major updated 2018 articles that are very conflicting. So they concluded in this trial, these patients who received hydrocortisone versus plus fludrocortisone versus placebo actually did have a 90-day mortality benefit. So what was really, really interesting about this study is the only other study to prove mortality benefit was the Anand study in 2002. This was the same author. What also is really interesting about this study is, do we all remember Zygris when it came into the market and then removed for the market? This study was actually powered to include a Zygris arm. And then when Zygris went off the market, because they collected patients over several years, they removed it. So now we're not actually, like our arm is not powered appropriately because we completely removed the other arm that it was supposed to be compared to. Corticotropin stimulation test was performed and results not reported, nor were non-responders analyzed. This article actually had patients who were very, very sick and had a much higher acuity than the adrenal study, and this may limit external validity. And the trial was conducted using the Surviving Sepsis Guidelines from 2008. We know that the newest update is from 2016, but because they collected patients for such a long period of time, this was all based on the 2008 study. I'll have a conclusion at the end. So last but not least, stress ulcer prophylaxis. As a pharmacist, I remember being on rounds with Dr. Nguyen and Dr. Emmanuel, who just presented, and we were like, oh man, this study is about to come out. The guidelines for stress ulcer prophylaxis are from 1999, and we're all gonna find out finally if pantoprazole or ranitidine or famotidine will be a better agent for stress ulcer prophylaxis in our patients. So why do we care so much about stress ulcer prophylaxis? Well, stress-related mucosal disease and critical illness, the reason that this happens is because we have an increased surge in catecholamines, decreased cardiac output. Now our patients are hypovolemic. We have pro-inflammatory cytokine release. Now we have increased vasoconstriction if they're on pressors. And now we have splenic hyperperfusion. So now we're not perfusing our stomach. We have decreased bicarb secretion, decreased mucosal blood flow, decreased GI motility. So all these things make our stomach very vulnerable, and this is why this is kind of a big deal for our patients. So based on those 1999 guidelines, we recommend stress ulcer prophylaxis, as you guys already know, if a patient is at high risk for coagulopathies, requiring mechanical ventilation for 48 hours, history of GI bleed, or if they meet any of the two following criteria below. So from a pharmacy standpoint, what pains me so much is inappropriate use of stress ulcer prophylaxis, right? Because every drug, which we sometimes think is benign, has side effects associated with it. We know that stress ulcer prophylaxis can potentially increase our patient's risk for C. diff, could increase our patient's risk for pneumonia. So if we use it inappropriately, then our patients are not receiving the best treatment. So in 2016, this study looked at 200 ICU patients over 9 months with a stay greater than 72 hours. 160 patients received stress ulcer prophylaxis. Almost half of them didn't even really have an indication for stress ulcer prophylaxis. And those who did, about 7%, did not receive stress ulcer prophylaxis. So about 40% of patients did not receive appropriate stress ulcer prophylaxis on ICU admission, and 80% were continued on inappropriate stress ulcer prophylaxis upon transfer from ICU. So how do we extrapolate that inappropriate continuation upon transfer to cost? Well, in 2007, before this trial came out, we were overprescribing stress ulcer prophylaxis and ended up determining that 80% of patients were continued on it after they left the ICU, 60% of that was inappropriate, and 24.4% was discharged with an inappropriate prescription, therefore giving us an unnecessary cost of about $15,000. So what do we care about with stress ulcer prophylaxis? As I previously mentioned, C. diff versus pneumonia. Is there a risk with PPIs versus H2RAs? Well, for C. diff, there was a meta-analysis. This other major study, McLaren and Phallic, looked at Clostridium difficile risk in various ICU patient populations and found out the meta-analysis showed that PPIs do increase that risk. PPIs in the Phallic study may have a protective benefit, which is really interesting. And then for pneumonia risk, these 3 studies demonstrated that there was no difference in pneumonia for PPI versus H2RAs. PPI sometimes had an increased risk of pneumonia versus H2RAs, and then there was no difference. So Maybe we do know that there is an increased risk, but maybe we don't know if PPIs have a higher risk versus H2RAs. So what's really interesting is that in 2015, this study came out, the CRAG study, and looked at 1,000 patients and showed that in the ICU, only 2% of patients had clinically significant GI bleeding, which resulted in hemodynamic instability, patients requiring blood transfusions, and the median time from ICU admission to bleeding was only 3 days. And if we look at the study that came out in 2016, the pop-up study that looked at pantoprazole versus placebo, barely anyone had clinically significant GI bleeding between the two groups, and there was really no difference in ventilator-associated complication or positive C. diff. So now, why are we caring so much about GI bleeding if these studies are telling us that basically a very small amount of our patients have clinically significant GI bleeding resulting in hemodynamic instability and blood transfusions? So this article was supposed to tell us everything, and it looked at patients emergently admitted to an ICU with an increased risk of GI bleed. Does administration of acid suppressive therapy with a PPI alter mortality at 90 days when compared to placebo? So we looked at pantoprazole versus placebo, randomized controlled study. It looked at patients who were admitted to a medical or surgical ICU, 90-day mortality, and it really showed that there was really no mortality benefit at 90 days. Clinically important events, really no difference between the two. GI bleeding, nothing statistically significant between the two. Pneumonia, C. difficile infection, not really different between the two. So is stress ulcer prophylaxis therapy really benefiting our patients? In conclusion, among patients admitted to the medical and surgical ICU with an increased risk of bleed, PPI acid suppressive therapy does not affect 90-day mortality in patients compared to placebo. What's really interesting about this study is that they did not meet their target enrollment. They didn't tell us about the feeding status of our patients. They didn't really tell us what other medical interventions had occurred. No serious events were reported, and clinical diagnosis of bleeds could not differentiate between stress ulcers versus other sources of bleeding. And it did not really tell us if the patient was on prior acid suppressive therapy. I'll skip my learning questions. So in conclusion, in our antipsychotics, no more use for delirium? Well, I won't deny a nurse if they ask for antipsychotics. This definitely facilitates a discussion. We know that delirium is a syndrome with multiple etiologies and there's no single treatment. Maybe we just don't really understand the pathophysiology behind delirium that well. So in an instance where a patient is very agitated or they have hyperactive delirium where they're having hallucinations, there is still a benefit of antipsychotics in that patient population. But should we utilize something like early mobility or ABCDEF bundle? Absolutely, because that is the part of critical care in our delirium that we have that evidence to support that. So the elephant in the room, mortality benefit of steroids and septic shock. So why did my adrenal study show that there was no mortality benefit, and why did the approaches study show that there was a mortality benefit? And why is it that this one author can always show mortality benefit versus any of the other steroid trials out there? Well, in the approaches study, this is why we love Journal Club, we love breaking down these articles and criticizing them, is that in the approaches study, they actually followed that golden window. They followed that hour. They really wanted to enroll patients to receive steroids as soon as possible, and the acuity of those patients were much higher than the acuity in the adrenal study. The adrenal study actually waited up to over a day before giving our patient steroids. And we know when our patient is very septic, refractory to fluids, we're adding on multiple vasopressors, we're kind of just throwing the steroids at them to see if we can find a benefit. And there really is a place in therapy for steroids because there is something that's really meaningful. The fact that we can reduce the amount of time that the patient is septic. And that's a really meaningful endpoint, despite it not being powered and wasn't the primary endpoint in the study. So this is something that we should consider, that there still is a place in therapy for steroids. And then last but not least, stress ulceration in the ICU doesn't significantly affect mortality. From looking at a lot of clinical trials, mortality is a really, really difficult endpoint to prove. And if we look back at that CRAG study, that showed that having a GI bleed or having clinically significant GI bleeding was not an independent risk factor for mortality. So by knowing that, now the study is trying to prove mortality difference. It doesn't really make any sense. We know that when a patient has a GI bleed or a GI ulcer, we have endoscopy, we have interventional radiology, so it's almost kind of silly for the study to try and prove a mortality difference. So something to consider is that PPIs, we know, are a little better at suppressing that acid production in the stomach. So there is a little bit of benefit from PPIs over H2RAs, and there really is, I guess, no difference in Clostridium difficile rates and pneumonia rates. So if there are patients who are at higher risk for bleeding in your ICU, there is still a role of PPIs in this patient population until otherwise better evidence is proven. These are some suggested readings. There are a lot of really great fluid articles that came out this year as well. And I will take any questions or comments at this time. Is there a window period for corticosteroids to be maximally beneficial from the time of diagnosis of sepsis to the time of administration of first dose? So as I previously mentioned, the adrenal study waited a very long time. I don't think any of us would ever wait over 24 hours prior to administering steroids in a patient with septic shock. And time is of the essence, which is what we know. That's why we have those hour bundles, 1 hour, 3 hour, 6 hour bundles for sepsis. So I think if we're able to obviously treat patients appropriately within that 1 to 3 hour time frame of receiving appropriate antibiotics, making sure they're adequately fluid resuscitated, and then starting them on the appropriate vasopressors, and then we start realizing that the patient is still refractory hypotensive, this is the key opportunity to using steroids, and demonstrated by the Approaches study, maybe timing of steroids really is of the essence. So I think the earlier, but with appropriate first-line treatment first, I think there is still a place of steroids in septic shock. Thank you very much. Thank you. I appreciate
it. So it's time for us to announce the abstract winner. This year, and again, this is our first year of Critical Care Symposium at Methodist, we had wonderful abstracts. We had a total of 12 abstracts, each asking really very valid questions in critical care. Out of those 12 abstracts, 5 of them were accepted, and I just wanted to mention the first name, the first author of each of the abstract. Brennan Parmalee, for palliative care units versus intensive care units, a review of studies comparing system outcomes. That was one of the submissions. Lee May Provencher, cryotherapy clot removal through a double lumen endotracheal tube, a therapeutic approach in management of massive hemoptysis. And the top 3 were Joseph Wynn Lee, assessing procedural competence across the educational continuum, development and validation of a central venous catheter assessment tool. Chelsea Lopez, Rameltion for decreasing delirium in surgical intensive care unit patients. And last but not the least, our winner of this year's symposium is Dr. Asma Zainab. Predictors of delirium in cardiovascular surgical ICU at DeBakey Heart and Vascular Center. Asma. I would like to call upon Asma. And I would request Dr. Masood to give her the award.
So there is the winner of these abstract for this year and onwards, for this year we'll give a $500 travel certificate to go for any educational activity and basically our appreciation. So Asma, congratulations.
Thank you very much, but I really want to thank Sahar and Richa, who were my interns. Can you please stand up? They're the actual force behind this abstract because they combed through 500 plus patient records to get us the parameters and then to do the study. So actually the whole, I was the idea behind it, but they are the force behind it. So.
And this concludes our morning session, but I have a few announcements. We will shortly break for lunch. The lunch will be served in the boardroom next door. There are more vegetarian options on the left line. And also, I just wanted to go over a few other issues, just sort of the ground rules for the afternoon workshop, which will be in the Dunn building. At 12:30 to 1:30, we have the break for lunch, and please, again, don't forget to visit our exhibits. At 1:30 p.m., based on your workshop registration, please make your way to your first station. A map is actually provided in your brochure to guide you to your respective sessions, and there are signs and volunteers helping you along the way as well. Your sessions are listed in the back of your badges, and the first workshop on the list will be between 1:30 to 2:30, and the second one will be from 2:30 to 3:30, and so on. Kindly go only to the workshop that you have signed up for to prevent any confusion. And most of our workshops have 10 to 15 minutes of brief overview followed by hands-on learning. And all the educational materials can be accessed on our website, as I mentioned, after the conclusion of the session. And at the end of 50 minutes, you're asked to move on to your next station, making way to the oncoming group. And you can only go to 3 workshops in total, and those who have registered late will have to find an open workshop that's not filled up, and please visit our registration desk to get more details. And thank you for attending our conference, and I'd like Dr.
Just one thing, on the workshops outside, there's a very nice creative artwork, and that's a brainchild of Dr. Dala. I just want to shout that. And it's always good to have women critical physicians to guide us in the right way. Thank you to all, and enjoy lunch.